Good afternoon. Can everyone please settle down and take your seats? We're about to reconvene. Okay, agenda item number 9, attachment number 14.90, request to establish a new level 2 HCPCS code to identify a fracture reduction orthosis. Trade name Bledo PHX, fracture reduction orthosis. Our primary speaker is John Tepper.
Good afternoon, ladies and gentlemen. My name is John Tepper, and I'm the Vice President of Product Development Engineering for Bledo Brace Systems, also known as Medical Technology, part of the United Orthopedic Group. I'm here today, let me start out by saying we didn't do a good enough job when we came here last year to describe the differences and distinctions between the Bledo PHX brace and other products that are currently on the market. So we respectfully disagree with the working group's L3760 recommendation for this product. First of all, though, I'd like to do a little bit of background for you on humeral shaft fractures. Humeral shaft fractures account for about 8% of all upper extremity fractures, and about 8% of those, or in other words 50,000 cases annually in this country, are distal third extra-articular fractures, which is the primary indication for the Bledo PHX brace. Again, that's a distal third diaphyseal extra-articular humerus fracture that does not extend into the joint. We're very confident that none of those 50,000 fractures were treated with a product coded L3760. The typical mechanism of injury can be falls. That's probably more prevalent in the older Medicare population, and also motor vehicle or industrial accidents and sports injuries. That results in kind of a bimodal patient population here, younger males and probably older females. This brace provides an alternative to open reduction and internal fixation surgical treatment. Open reduction internal fixation, or ORIF, is the standard of care, we believe, for this type of fracture. It's typically about a 3-hour surgery that's fairly complex. It's usually an inpatient hospital stay, although, as we'll see, there's a few done on an outpatient basis. It's a relatively costly surgery, which we'll see in a minute. In addition to the surgeon's fee, the anesthesiologist, and the hospital stay, the plates and screws, the hardware that's used in the procedure, can be $3,000 to $5,000 alone per case. However, ORIF has good clinical outcomes. The surgical fixation minimizes or eliminates varus deformity, which is a common complication with other means of treating this kind of fracture, and it results in good union rates of 85 or 90%. However, as I mentioned, this is a fairly complex surgery with some significant risk factors. Probably the primary one is radial nerve palsy, dropped wrist, in approximately 16% of cases. In addition to that, there are other typical surgical complications: loss of fixation, infection, and non-union. To date, and I'll show some clinical data for this product, there are no significant complications with the Bledo PHX brace. Activity restriction, recovery time, similar in both cases. So, for some patients, the Bledo PHX brace, we believe, is an alternative to an ORIF-type intervention. The picture on the left here shows the surgical exposure, the dissection required to put in the plates and screws from the shoulder all the way to the elbow. When the surgeon performs this surgery, he's got to avoid the radial nerve, which is what makes the surgery fairly tricky and what can result in the complication. We think the Bledo PHX brace helps avoid the complications and expense of the surgery, and particularly iatrogenic nerve injury. Cost-wise, for inpatient surgery, the average cost is over $14,000 per case. The much less common outpatient surgery, almost $9,000 per case, compared with an estimate of $1,700 when treating with the Bledo PHX brace. I want to go back and look at this picture. We're going to look at an alternative way, which is traditional fracture bracing, which can often lead to the varus deformity or gunstock deformity that we can see here, which is typically a 15 to 20%. It heals with 15 to 20% angulation. Here are some of the traditional fracture braces. These are coded as L3980, and these braces are not indicated for fracture reduction. They merely go over typically a mid-shaft humeral fracture that is in good alignment and holds them in alignment. The reason why these are not comparable to the Bledo PHX brace, this brace here has some capture of the deltoid of the shoulder, but does not come down and capture any of the elbow. This brace here captures a little bit of the elbow, but does not come up and capture the deltoid, and therefore is not able to immobilize a joint above and a joint below the fracture site, which is the standard for fracture immobilization. To draw a distinction, and I think this is where we weren't clear enough with our presentation last year with the Bledo PHX brace. This has a significant number of features that work together to reduce and align the fracture and enable it to heal. There's 5 main components: the humeral cuff, a figure-of-8 shoulder suspension that works in conjunction with the deltoid cap to keep the shoulder immobilized, a range of motion joint at the elbow and the forearm support that immobilizes the joint below the fracture site, and then our patented fracture hinge, which enables the surgeon to reduce and align the fracture. And I want to point out that the surgeon does this procedure. He's got to consent the patient, unlike any other brace that we're aware of on the market, has to consent the patient for a manipulation and closed reduction procedure when placing this brace and reducing the fracture. As I mentioned, we've got some additional clinical data since we came and presented to you last year. Our investigating surgeons have completed a series of 18 patients which have gone on to a solid union using this product. We look at the initial average angulation, 17 degrees. The average healed angulation, less than 4 degrees for each of these patients, which is almost an 80% angulation reduction. In addition, we have some special lining materials that we've had no skin breakdown, irritation, or maceration issues in treating with this product. Let me back up a couple slides. These products are always used, or almost always used, in conjunction with a stockinette, and skin breakdown and other skin complications are very common, almost universal when using products like this over an extended period of time, particularly depending on what the local weather situation is. Let's look at this in a little bit more detail. I've got here an initial X-ray as presented in the ER of an injury, and here's the patient after having been consented and having the reduction operation performed by the surgeon with the fracture fragments essentially in alignment. The hinge has been deployed to keep them aligned here. And we're going to hear from a high-functioning patient who expects good alignment on healing and wants to avoid the risk and complication of surgery.
I've played baseball for roughly 15, 16 years. Pitcher all the way throughout. Second inning of the first game, regular routine fastball, nothing special about it. Pitched it and heard 3 cracks. That was it. Dropped on the ground and my arm was just not connected to my shoulder anymore. At the emergency room, once I found out the 3 fractures, I was told there's an orthopedic surgeon within the hospital, and after talking with him, he was leaning more towards the Phoenix brace just for the reason that there's less complications down the road, less chances of re-breaking my arm. It sounded like the best plan for me and to get me back into shape to play baseball again later down the road. After I visited with Dr. Grant, I was put in the brace. He would tighten the cuff and the hinges where it would straighten out and align my bones. I was glad I was given the option to use the Phoenix brace rather than my only option is surgery, and it's essentially rehabbing with it on, whereas surgery at the weight. 3 months later, I'm out of the brace, arms twice as strong as my left one, and I can lift, more weight, it's ready to go back to baseball.
The working group's recommendation was for a L3760 code. And once again, we respectfully disagree with that because L3760 products are indicated for post-op stabilization only, for ligament and small bone fractures of the elbow joint. It has a position-locking joint to control flexion and extension only. It is not indicated for treatment of an injured arm by reducing, aligning, or immobilizing the distal third of the humeral fracture, and it doesn't enable active fracture reduction. And by that, what we mean, after aligning the fracture and reducing it, the surgeon will follow the patient over a number of appointments in the office to make sure that it maintains alignment, and he can adjust during the process to make sure that the fracture alignment is there for healing. If we look at the x-ray here on the left, this is what a patient would look like in an L3760 brace. We've got 14 degrees of malalignment here, and because the brace does not come up any higher than the level of the fracture, there's no way that you could reduce or stabilize that fracture. That's still an unstable fracture. The difference is when the hinge is deployed, because we have the deltoid cap, the cuff, and the range of motion hinge with the forearm extension, and most importantly, the patented fracture reduction hinge that takes care of the varus deformity. We can deploy the hinge, which is during the reduction procedure, to line it up within 3 degrees or so, or better, to keep the fracture in line and enable it to heal. So our summary and conclusion is that we don't believe that there currently is an HCPCS Level 2 code descriptor that sufficiently describes the Bledo PHX brace, so we respectfully request a new code to describe this type of product. And our suggested language is upper extremity humeral fracture orthosis, shoulder, elbow, wrist, hand, shoulder cap design, includes 2 or more non-torsion joints for non-surgical fracture reduction with varus valgus adjustment, adjustable positional joint, may include soft interface straps customized to fit specific patient by an individual with expertise, in this case, an orthopedic surgeon doing a closed reduction and manipulation procedure. We think that the Bledo PHX fracture brace is a lower risk, less expensive alternative to surgical intervention. Unlike an L3760 product, it's not merely a post-operative stabilization brace. Unlike L3980 braces, it can actively align and reduce the fracture, and that's because of the published patent for the bone fracture correcting hinge. And once again, we do think that this product does require a new code, and we thank you very much for your time and attention. Happy to answer any questions after our 5-minute speakers.
Our first 5-minute speaker is Greg Grant.
We're out of order. We'd like to have Kelly Nolan, I think. Is that okay?
Okay, no problem. Can I have Kelly Nolan, please?
My name is Kelly Nolan. My background is physical therapy and athletic training, but I'm currently the Senior Product Manager at Bledo Brace Systems for upper extremity products. And what I brought were some samples of a 3760 brace, just so for reference. As you can see, it's just a very simple, you have a forearm strut, you have an upper arm strut. There's no plastic cuff or anything that actually captures the fracture site. It says brace is not designed for fractures. And it just has a very simple hinge. So just for range of motion. This is designed for soft tissue injuries to the elbow. And as John said earlier, minor fractures to the joint. So that's just a sample, just for reference. Now this is the Phoenix brace. As you can see, it has a shoulder cap design, and it has the plastic cuff for a fracture, the capture of the arm for a fracture, proper healing of the fracture. Once you get this in position, one of the biggest problems that you have with a fracture cuff, like the ones that are on slide 5, is that they're set to a certain size, and unfortunately, if you try to get the capture of the cuff, sometimes it doesn't come down far enough to capture the elbow. Or if you go with the other type that actually captures the elbow, you don't capture the upper part of the arm, so the arm can actually move inside that cuff a little bit. So you have nothing that's actually capturing the both ends of the fracture site because you want to stabilize it. Sorry, I don't have my glasses on. I'm kind of doing this by braille. But that gives you a real good capture, and you can see how it captures the shoulder. The straps support it and keep it up, keep the suspension so it doesn't slide down the arm. With the forearm, you capture it. So now this is all one unit. So now you can see it's got the whole arm captured. One of the problems with just a regular cuff is that you can actually rotate the fracture inside there, or if it's captured here, you can actually get some angulation at the top, so that's how you get that gun stock deformity that was shown in the one slide. Now the arm is one complete unit. Now the part that's unique is that, as John was saying, is that we have a patented hinge here, and on this one you can see how if I loosen this hinge, I can actually manipulate this arm all different types of positions. So once I have the arm captured, and that fracture is stable or in place, I can actually position it to wherever I want to put the varus or valgus to get those bones in alignment. And then there's 2 set screws that you lock it in place, and it stays with that amount of load on the side of it. And the patient will be coming back, as Dr. Grant's going to say, for follow-up visits. So if there is any additional modifications or adjustments, they can actually make those adjustments to make sure that that arm heals in the correct position. The other thing that's nice about this is one of the biggest problems with the rehab aspect of a humeral fracture is not the fracture site, it's actually frozen shoulder or a contracture in the elbow brace, or the contracture of the elbow. So what this brace does, now I have the whole arm stable, I can actually start doing some real light Codman exercises, like pendulum exercises, that they can actually get their range of motion started at a much earlier phase, so now you're not treating them for frozen shoulder. Eventually, as this heals up, the doctor may want to progress into some range of motion of the elbow so you can kind of free that up so it doesn't scar down, because that's usually the biggest frustration in the clinic was I'm treating these 2 joints and not actually, other than just some strengthening exercises for the muscles, but this actually does a real good job of capturing and aligning. I wish I had this when I was in the clinic. I thank you guys for listening, and hope you guys consider changing.
Our next 5-minute speaker is Dr. Greg Grant.
Good afternoon, ladies and gentlemen of the HCPCS committee, and thank you again for letting us come back. And my apologies, I take some responsibility for last year for not adequately demonstrating the difference of a PHX brace and the various other braces that are available on the market. I think we spent most of our time trying to show the efficacy of the Phoenix brace and how well it heals fractures, but didn't differentiate this brace from the other braces on the market. I'm one of the inventors. I'm also one of the investigative surgeons, and have been speaking around the country on the use of this brace at our various academy and orthopedic trauma association meetings. Bledsoe did pay for my transportation here today, and I don't have any financial arrangement right now with the company. This brace is obviously not a 3760. My apologies for the slide that we had up here. We had one slide of a patient that I just had recently. It came to our attention that if it's a 3760, what does it actually look like on one of these fractures? I had a patient that was about 3 weeks into treatment, and we had to remove his PHX brace because when they come to the office about every 10 days to 2 weeks, we do take the brace off to examine the skin underneath it, make sure there is no skin breakdown, and then replace the brace. While we were doing that, I actually asked the patient, since we're publishing a paper on this, if I could take an x-ray of the 3760 elbow range of motion brace on his arm. So put it on and walked him across the x-ray and took an x-ray, and unfortunately it didn't show up very well today. But the 3760 only comes up to the top of the fracture. Luckily, he was 3 weeks, and I wouldn't have done it with a fresh fracture because really there's nothing to stabilize the arm. With the brace on, the arm is not stabilized. They're very painful, and it doesn't correct the angulation, much less even immobilize the fracture. And that's below the standard of care. There's no state in the United States that 3760 can be used to treat these types of fractures. That's not the standard of care. It falls well below. Probably be considered malpractice had I sent that patient out with that brace on. Is it a 3980? Well, no. 3980 is our standard Sarmiento, and it just keeps the fracture in the current alignment that they come in. It really does not do any correction whatsoever. Obviously, if it's something that's 45 degrees and you put a straight brace on it, it's going to straighten it out a little bit, but they all heal typically with about 15 to 25 degrees of angulation. Since I developed this brace in 2003, touch wood, I have not had to operate on any of these distal humerus fractures anymore. We've actually extended it into the mid-shaft fractures. We do have quite a few mid-shaft fractures that come in, and the Sarmiento, they were placed in a Sarmiento. It didn't line it up. We've actually placed them in the PHX brace, and when we've been able, just mild angulation of the patented hinge, we've been able to align these fractures. I've not had any non-unions. I've had no nerve complications. Obviously, we don't have any of the surgical complications. Yeah, I know we're not supposed to talk about costs, but it's something that we talk about all the time, the rising costs of healthcare and the system going bananas with expenditures right now. Roughly of those 50,000 distal third fractures, until this brace was developed, I always had to operate on these. Every orthopedic trauma surgeon in the United States always had to put plates and screws on these, usually a double plate system like you saw. Now we have locking plates, so we can just put one plate on the lateral aspect of the humerus. It's a very lengthy surgery. It's one that I'm a traumatologist. I like fixing broken bones. This is one I don't like fixing. I have to lift the nerve up and slide that plate underneath it and hope like heck I don't damage the nerve getting the plate on. If we were to operate on all 50,000 of those, that's roughly $700 million that it costs the healthcare industry in the United States. If those 50,000 were treated with a PHX brace, that total cost comes to about $85 million. We're saving a considerable amount of money in the healthcare system. I wish other doctors like myself thought about that when we do a lot of what we do, because I'm very conservative. I'm very conscientious of the costs. If it were me, I would not want my arm operated on. If I can get my fracture reduced and heal like that and spare a great big ugly scar in the back of the arm, plus or minus all the possible complications, I'd take this any day of the week. Obviously, I'm biased. I invented the bloody brace, but having said that, we actually have this brace has now been available through Bledsoe, and it's been sent throughout the country to other trauma facilities. Everybody is very happy with the brace. We've had no complications of the brace so far. Unfortunately, I don't think, obviously, I absolutely do not believe the 3760 matches this brace. The fact is, this very powerful, we have 3 braces in one here. This is essentially a figure of 8 brace. We actually took a figure of 8 brace and modified it to make this. If you try to pull the fracture through here, all it does is it'll pull this off the shoulder. If you just use a simple strap that comes with the Sarmiento, we had to have a very strong, very rigid figure of 8 system to keep this mounted and keep it down as we're reducing the fracture. Likewise, it's not a 3980. 3980 goes from here to here, and the problem with the 3980 is the fracture is the distal third, and the Sarmiento basically only comes down just above the elbow joint. It does not actually go below the elbow joint. So it really doesn't stabilize the fracture. They can still move in their sling. They're painful. So with all due respect, I disagree with the finding, and I'd be much appreciative if the committee could grant a new code for this brace.
Sure. Mm-hmm.
I would just be interested to know the population you have no complications, but are you choosing how many have you done with using this? Are you choosing them specifically, like non-smokers, blah, 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 to get so that their non-unions are not going to happen? I mean, I find it very hard to believe you've not had any complications whatsoever. I come from an orthopedic background. And
it is the absolute worst thing to say we've had no complications, but the complication that we have, if you want to list it as one, is it's not perfectly aligned. As you can see from our, since I was here last year, Dr. Vanderhoof and I have had another 18 additional patients. We take all comers. There's no patient that is picked out for this brace. Nobody's excluded for this brace. I actually prefer using this brace on older folks. Their bone is they typically have osteoporosis after they're over age 70, 75. The screws don't anchor as well, and skin complications are quite significant. So especially in the older population, you say, well, you probably don't want to operate on those. You want to operate on all young, healthy baseball players. But we actually prefer to treat the older patients. They heal just as well as younger patients do. And they're the ones that are most apt to get the skin complications from surgery. It's very difficult to put subcutaneous sutures in those and put a great big staple line up the arm. They just do not heal very well, and the hardware failure is significant. So to answer your question, no, we have not picked any patients for the study. It's been all comers. I work at 5 different hospital systems in the Phoenix area, taking call almost 30 days a month, 25 just at one hospital alone. And now that this brace has been released, a lot of people in the community know about the brace. Hanger has been kind enough. They're the ones that are fitting the brace for us, and then the doctors are the ones doing the actual reduction. But we're getting all comers from all over the Phoenix, Maricopa County area, and we've actually had some patients sent down from Flagstaff as well.
So how many are we talking?
Since 2003, I've probably got well over a couple hundred patients. Just since the Bledo has, we took my patented hinges and then incorporated them with this Bledo brace. Since the Bledo brace has been available, we have probably about 75 patients now. Just between the 2 investigational surgeons, we have about 40, and then there's been others that I think have been sent. There's another 10 doctors around the country that are using it, and I don't know how many braces have been sent out to all those doctors.
Thank you.
Okay, at this time. Oh,
well, sorry,
one more
Felicia,
question.
I was trying to turn it on. The brace is applied in the emergency room or in the physician's office or in the hospital setting, or where's the brace applied?
There's 2 answers to that. Typically when these come in, these are very painful injuries, whether it was a guy that's wrestling or somebody who's just fallen down and landed on their elbow. They're quite painful. Our recommendation in orthopedics is for a coaptation splint to be placed. So that's basically a plaster slab or fiberglass slab that goes from the top of the shoulder around into the armpit, and then a slab that goes around the forearm, and then they're placed in a sling, and they're typically discharged. They come back to our office in 5 to 7 days, at which time the swelling is already maximized. It's now starting to come down. Their pain at 5 to 7 days is much less. If I tried to put this on in an emergency room setting, I'd probably get hit a few times because you can't manipulate an acute fracture like that. The second answer is older folks. You can't really send grandma out in a big coaptation splint. The ER puts grandma in the coaptation splint, but they're not safe to discharge home. So those patients are brought into the hospital. With Medicare law, they have to stay in the hospital for 3 nights. During that stay, again, it's difficult to discharge them out to a care facility, extended care facility, or home in that type of splint, and so those are actually placed in the hospital in the Medicare population.
Thank you for your presentation. I have a few questions. So you state that this is not a 3980 because that only ends at the, basically at the elbow. But I've made several types of braces using different prefabricated components where you can use a 3980 with an elbow joint and a forearm. Mm-hmm. And so you're basically getting some of that stabilization that you normally can't. So I think that's an indication of what you want to treat in your facility and what components you pick and choose that are appropriate for that diagnosis. So I think there is some leeway. It may not be a 3980 by itself, but you can use a 3980 with it. So I think what I'm looking at when I see this is I'm trying to understand, is this an orthosis for fractures only? Mm-hmm. And what's the uniqueness about it? Is it just your patented hinge? Because everything else tells me there are codes that describe this orthosis. Mm-hmm. And so can you answer those two questions for
Yes,
me?
absolutely. If I may even digress to when we first put this together. I may have mentioned last year I had a huge wrestler that came in with an arm this big around when I first started practicing. I had only been practicing a couple of years, and I asked myself the question, why don't we have an orthosis that fixes distal third fractures? The Sarmiento doesn't align it. They're crooked. And so I actually went to one of the hangar facilities, to their lab, and I took a Sarmiento, and I took an elbow ROM brace, and I riveted the outer skeleton to the Sarmiento and put it on the patient. Problem is it was still in a little varus. It's about 10 degrees of varus angulation. I took it off. I literally bent the brace over my knee and right here and bent it out about 10 degrees, and I put it back on the patient, and lo and behold, the fracture lined up. Problem is, the Sarmiento comes with a little strap that comes underneath the arm here. It's a very weak strap. So what happened is it just pulled off the body. So I thought, well, how can we keep this strapped on and comfortable? Well, a figure of 8 brace for clavicles goes around the other side, is pretty strong. So I drilled 2 holes in the deltoid cuff and rerouted the figure of 8 through the top of the deltoid cuff and around and under the other arm, which then mounted that for me. Well, how are you going to produce something like that you bend over your knee? And so my last thing is I found a pediatric abduction brace for children with dislocated hips, and I took that little hinge there and welded it and riveted it in the middle right here, which then allowed me to undo a single nut and deploy the hinge so that another practitioner could do it with precision, not just bending it over your knee. These have teeth in them. You know the degrees that you get with the movement of each tooth, and then you set it there. And that's when I came up with the idea that there was no other prior art on the market with a hinge that went here that allowed that reduction. So that's what led to the development of that patent. So basically, there's 4 components in here. You got your elbow ROM brace, you got the special patented piece that I came up with, a Sarmiento, a figure of 8, and then it's another conversation. But even with this, with an acute fracture, just hanging here is not all that comfortable. So I often recommend that we put a little pillow with a sling on it for him, just to keep the arm stable so it's not moving all over the place within the first couple of weeks. As soon as we start having some bone healing occur, I actually take the pillow away, let it come down, and at 2 weeks for a proximal humerus fracture, we already start common exercises at 2 weeks. So I actually start common exercises in the brace. Once I get enough healing, then we take the hinge back into the plane of motion, and I unlock the elbow range of motion brace. So really, I've got 4 components, and if you add the pillow, that's 5 components. I mean, I don't want to come before you and ask you for 5 codes to meld together, but I guess that's, to your question, that's sort of where we would go.
Well, I think what you're describing as a fracture orthosis, it may be a unique design that you came up with, but it would fit the definition of a fracture orthosis. And so can you use this, or is it used for anything other than fractures?
It certainly can be. Obviously, what we've taken here is this up to the deltoid. It gives more rigid fixation of the entire arm. So if you had a more serious injury here at the elbow, and the cuff only comes to here, and you really didn't want rotation, say you've repaired a distal humerus fracture that's into the joint, and you've got lots of screws with an unstable joint, and you just put an elbow ROM brace on, that doesn't prevent the torsion. You got to actually grab the shoulder.
But the primary diagnosis would still be a fracture.
It would still be fracture.
Right. So
I can't think of any ligament injuries like reattaching a biceps or repairing a triceps or doing any type of shoulder rotator cuff surgery that would benefit from. I think it's
so
purely
if I took
fracture.
prefabricated, say Sarmiento as you describe them, cuffs, and used your joint in a figure 8, would I not have the same type of device?
As long as we grab across the elbow joint. You got to go across the elbow joint to grab the arm to be able to lever it, yes.
Okay. What I'm trying to get at is just looking at the category and classification of the device and not so much the specifics about yours, but what's unique about it or what's different. And I
There's like a
understand the
base
joint.
code, for example.
Right. So there's base codes for fracture orthoses. And what I'm trying to see is what's the uniqueness. Is it the hinge? Is it, like you said, different combinations of things? But a figure 8 harness does exist already. There's a code for that.
Yeah.
And those types of things.
Right.
So.
The 2 things I think is fracture reduction, and second, I don't think there is any brace on the market that comes above the humerus to the shoulder and below the humerus to the elbow. So I guess that's what is.
They don't sell them that way, but you can certainly buy a humeral cuff with. I mean,
Hinge is unique as well to be able to align the fracture and take care of you can adjust a varus and a valgus deformity.
That's right. I take my answer back. Coflex does make something that's a Sarmiento, and it has just a simple uniplane hinge at the elbow with a cuff on it, and it just does this, but it doesn't reduce a fracture.
Okay, thank you.
Thank you. I just wanted to point out that the code language that our primary speaker recommended, Mr. Tepper, is not what was submitted in the original application by the applicant.
That's correct. We had some subsequent discussions after the application, and that's why what's on the slide here is modified somewhat from what we put in the application. I think we would be happy with either of those sets of languages. I'm not sure that's the right term, but you're correct.
I'm just not I'm just uncomfortable with someone other than the applicant making a suggestion to change the application.
That was our suggestion as the applicant. I think. Pardon? Bledo Brace Systems is the applicant, correct? Or I may not understand. Oh, okay. Got it. All right. Okay. That's my boss. So, okay. Okay. All right.
Okay, thank you.
Thank you for your time. Appreciate it.
Thank you very much.
Agenda item number 10, attachment 14.89, request to establish 5 new HCPCS codes to identify a epiretinal prosthesis system, known as the Argus II retinal prosthesis system. Primary speaker is Brian Mesh.
Hi. I'd like to thank the coding committee for the opportunity to make a public comment on this. My name is Brian Meck, and I am an employee of Second Sight Medical Products, who's the applicant on this. We are requesting 5 new HCPCS codes for the Argus II system and its related components, and the preliminary decision was that there's no programmatic need for that at this time. In my talk today, I'm going to go over the clinical need for the Argus II and the disease that it helps, retinitis pigmentosa. I'm going to describe the system and how it works, which I think is really important in this coding decision. I'll touch a little bit on the substantial clinical benefit, but I won't spend a lot of time there, and then try to convince you that, in fact, there is a programmatic need for these HCPCS codes. So in terms of the clinical background here, the Argus II treats retinitis pigmentosa. RP is a progressive inherited disease of the retina that leads to total blindness. It affects about 1 in 3,500 people in the United States, and it's the patients that we're treating are largely Medicare population by virtue of the disability. The patients that are eligible for the Argus II have no functional vision, and except for the Argus II, there is no other treatment alternative for these patients. This is a little bit about how the system works, and I'm going to make the analogy to a cochlear implant, because essentially this is a cochlear implant for the eye. But instead of using a microphone, we use a video camera, and instead of stimulating in the cochlea, we stimulate on the retina. This slide breaks down the components of the system. So the patient has a head-mounted system that has both the video camera and a telemetry system and a cord that goes down to this visual processing unit. So this is equivalent to the speech processor in a cochlear implant. The video processing unit allows the patient to control the type of imaging strategy that's being employed at any given time. Here you have a picture of the implant that's surgically installed, and this is the array located on the retina over the macula. Data and power are wirelessly transmitted to the implant, just as they are with cochlear implants. And we provide a 20-degree visual field of view using 55 independently controlled electrodes. The Argus II retinal prosthesis is indicated for retinitis pigmentosa patients that are profoundly blind. They're 25 years of age or older, bare light or no light perception in both eyes. They've had a previous history of useful form vision and are willing to participate in the rather rigorous postoperative routine that comes with getting this surgery. It was approved last year by the FDA, and it's worth noting that it affects the annual incidence of patients meeting this label is about 250 per year. The device is installed surgically in a 4-hour procedure that is typically done on an outpatient basis under general anesthesia. It consists of a series of vitreoretinal surgical steps that are performed fairly often by these surgeons, but this is a unique and complex combination of them. The data from the clinical trial has been published in peer-reviewed literature, and it showed that the patients did, in fact, receive a substantial clinical benefit from the Argus II retinal prosthesis system. It allowed them to better perform activities of daily living and improved quality of life. And in fact, CMS, in reviewing this data last year, determined that it did result in substantial clinical benefit, and I'll come back to that in a moment. This is a slide that just indicates some of those activities of daily living that the patients noticed an improvement on, including the ability to sort laundry, the ability to stay on a sidewalk when they're ambulating, and the ability to both note the presence of other people and identify when they're moving and in which direction. In addition, we've had tremendous professional society support and patient advocacy support in terms of ensuring patient access for this device. The American Academy of Ophthalmology, the American Society of Retinal Surgeons are both supportive, as is the Foundation Fighting Blindness based here in Baltimore. As I mentioned last year, CMS recognized the clinical benefit of the device, and they issued both a new technology add-on payment in the inpatient setting, along with new ICD-9 procedure codes, and in the outpatient setting authorized a transitional pass-through payment and issued a new C code, C1841. However, neither of these events provide permanent coding for the Argus II system, and in fact, no coding whatsoever for the replacement parts. This slide just speaks to the fact that the Argus II, just like a cochlear implant, is a prosthesis. It meets the Medicare's definition of a prosthesis, and that's why we're asking for L codes. So the program need, I think, apart from the fact that the codes don't exist, that certainly creates a need. But in terms of utilization, coverage is expanding constantly. I have a list here, a partial list now of both Medicare contractors and commercial payers that have positive coverage policy in place. And there are several other payers that are authorizing coverage for the device as well. So utilization is increasing, and as is patient access. So to summarize the programmatic need, there are no permanent codes for the Argus II retinal prosthesis system, and our temporary code will expire. And there are no codes whatsoever for the replacement parts that are necessary for these patients to continue to function if something should go wrong with their battery or their head-mounted system or their visual processing unit. So the HCPCS nodes are needed so that providers can bill and receive payments for furnishing these replacement parts. This summarizes the 5 codes that we've requested. One is for the entire system, one is for the head-mounted telemetry and video data collection system that you saw, another for the video processing unit, and one for the charger and the battery itself. And I think lastly, I just wanted to indicate that there's a very clear precedent for this coding approach that we see both in cochlear devices and in auditory osteo integrated devices, where there is a code, an L code for the entire system, and then additional L codes for all the analogous parts to our system when they need replacement. So with that, I would conclude and invite your questions.
Hi, thank you for your talk.
Thanks.
How many have been implanted as of this date?
As of this date, there's been 5 implanted.
Thank you. Because I think you could understand that we don't create codes for 5 people's things. Those can be covered with miscellaneous codes. So once it catches and grows, which we hope it will, there might be a need, but right now with only 5, that's not really something that we would develop codes for.
I think that's a fair criticism, and I understand that perspective. I think you have to understand that, number one, we're treating an orphan patient population here, so that might push us into always using miscellaneous codes. But the miscellaneous codes themselves, at least as I understand it, are challenging, especially when we're talking about payment levels that are fairly significant. So I think without a specific code, it's going to be challenging, at least at the implementation level. And I think for these patients and for the providers here, when the reimbursement picture is not clear, one of the things we've been seeing is that it's hard to get the providers to onboard the technology. So even though CMS has been tremendous for us, I would say, in what they did for us last year, the fact that the coverage situation across the country is different has made it challenging to onboard it. And whenever there's a question about reimbursement and codes, the administrators get nervous.
I think you can understand that every single payer in the whole, our whole country would have to add the codes, and you're not just asking for one code, you're asking for several codes, to add all of those for what's right now 5 patients.
Yeah, so as of today, it's 5 patients, I think.
I know.
Right.
I'm just saying you have to understand where we're coming from at this point in time.
And I do understand.
I have a comment. You said that there is this surgery is outpatient, right?
I said mostly performed on an outpatient basis.
Okay, where outpatient means it's in ambulatory surgical centers?
Typically, it's in a hospital-based outpatient facility.
Okay.
But it could presumably be in an ASC.
ASC. And at this time, you have the C code?
Yes.
To pay for it?
Yes.
Okay.
So that pays for the system that they get when they are implanted.
Yes.
So the L codes are for the replacement components. If something, so basically, if something goes wrong, these patients can't use their system anymore. If their glasses break, or they sit on them, or they lose them, or they drop the visual processing unit and it breaks, they cannot use the system anymore.
Yeah. Is there a warranty for all these products for the time being?
There is a warranty. On all the external components, there's a 1-year warranty.
Okay. Yep. Thank you.
All right, thank you.
That item concluded our orthotic and prosthetic portion of today's meeting. We're moving on to DME. Agenda item number 11, attachment number 14.94, a third request to establish a new level 2 HCPCS code to uniquely identify a fiber optic targeted phototherapy device, trade name Livia or Livia system. There is no primary speaker and no 5-minute speaker. Is there any questions or comments? Okay. Moving along, agenda item number 12, attachment number 14.102, request to establish a new level 2 HCPCS code to identify ultraviolet multidirectional light therapy units designed to treat hands and or feet for multiple dermatologic conditions. Trade name hand/foot 2 phototherapy device. Primary speaker is Kenneth Oif.
I'll go with the other. Mhm. Okay, thank you. Thank you very much. Appreciate the opportunity to speak to the HCPCS planning group. My name is Kenneth Oiff. I am the CEO of National Biological, manufacturer of home and clinical ultraviolet equipment. I am a principal and shareholder of the company in terms of financial information, financial disclosure. Today we're going to talk about the hand-foot system. We did bring the piece of equipment to try to give some detail in terms of the three-dimensionality of it. Sometimes the slides don't offer us that ability. Currently, the hand-foot ultraviolet machines, and by the way, we respectfully do disagree with the panel's decision of the preliminary finding that the current description is descriptive. And we'll try to go through our presentation and do our best to contrast what is currently being offered in the market, not just by us, but our competitors as well. And then we'll hopefully come to a conclusion here in terms of what we are asking. The current hand-foot ultraviolet systems are not described in the current code, and they're causing challenges for both patients, payers, and providers. We are typically using code E1399 for this device, and I'll show momentarily why this is a requirement. The new request is for a code E069X, and we've just filled in the X, maybe an entirely different code that gets represented by the HCPCS panel. It would be requested for an ultraviolet multi-directional light therapy system for hands and or feet, including bulbs, timer, and eye protection. The preliminary decision of E0691, ultraviolet light therapy system, includes bulb and timer for treatment area of 2 square feet or less. And we're going to talk about why we feel that is not descriptive. Talk quickly about psoriasis. Psoriasis is a chronic condition. It afflicts about 2.5% of the U.S. population. Specifically, we're going to be talking about palmar plantar as a subset of the psoriasis category. Palmar plantar affects about 15% of the population. It is a very difficult condition. It typically involves the hands and the feet. Patients describe it as walking on hot coals. It is typically talked about as having cracking and bleeding. Why it's even a more difficult situation than typical full body psoriasis, because the criticality of hands and feet walking on them obviously exacerbates the plaques and makes it extremely uncomfortable, if not debilitating. It is very difficult to control, according to Dr. Alan Mentor, who is one of the country's foremost gurus in psoriasis treatment out of Baylor. It is notoriously difficult to treat and unresponsive to topical treatments, which is the necessity for a more complicated system, whether it's a device like ours or some of the biological medications we're going to talk about here. It requires very, very long treatment times. So the plaques on feet and hands, very thick. A typical treatment time per treatment area is about 5 to 10 minutes. So typically a patient would place their hands on the grid and illuminate the treatment and like. As I mentioned, about 15% currently of psoriasis sufferers have palmar plantar condition overall. Picture it is the hand and foot unit, and the unique features of it is a multi-directional system. And as such, it requires not just a planar or single level like the 2-foot unit as pictured up on the screen, and we'll talk about why we feel the current codes are not descriptive. But we come as an industry member not just for our company, but also to represent our competitors as well. All 3 of the major manufacturers' units are more than 2 square feet. So the code itself is not descriptive or representative. The National Biological Unit is 2.87 square feet. Our 2 competitors are similarly sized, as larger systems. These codes were designed, by the way, in 2002, before a hand and foot system was readily available to the public. They were prior to that available only in a medical office setting overall. Let's look at the 4 codes that were from 2002. EO691, which of course is the code that is being suggested for this device, is again a treatment area of 2 square feet or less. EO692 is a 4-foot panel. EO693 is a 6-foot panel, and EO694 is a multi-directional panel. What is very important is there is actual precedence to the multi-directionality in terms of the 6-foot unit. There's a 6-foot panel, and then there's a 6-foot multi-directional unit to treat other than a planar surface. And that's why we are also suggesting a new code be developed. So the work group has consistently used 2 main criteria: the size of the treatment area, as well as I mentioned, the multi-directional aspect or the single planar. And Mike, why don't you come up here? The hand-foot units do satisfy both conditions, and again, do not fit under the EO694 code. So one of the challenges is palmar plantar involves the top of the foot. It's not just the bottom of the foot. For a hand condition, which is a much less critical area, an individual could turn their hands over and use, in theory, a 2-foot panel for that. But you can't do that with your feet. It is anatomically impossible. Mike's going to try to do that here. So he could treat the top of his feet, but even if that unit were laid down on its side, which is not how it's designed, it is virtually impossible to do it unless the person's a contortionist. And since a lot of users of our systems are seniors, it's a substandard treatment, if you would. In addition, smaller units can't be utilized. There is tremendous risk, as I mentioned. You have a 5 to 10 minute exposure treatment time with a smaller unit. I did bring also another unit that technically fits under E0691. It is a handheld device. One can say, in theory, you can use this to treat the bottoms of the feet for that 5 to 10 minute kind of treatment time. You run the extreme risk of overlapping treatment and therefore erythema, which makes it even more challenging for that patient and is actually quite dangerous. Ultraviolet light is very much a commonly prescribed by physicians and has been. As I mentioned earlier, it also comprises of about 15% of the prescriptions that we receive throughout the country overall. Incidentally, based on our historical data, only about 40% of the prescriptions currently are filled because of the complications with E1399. This compares to 71% of the prescriptions that get filled under the more traditional full body units, the 6-foot units, or the multi-directional 6-foot units overall. It is also a contributing factor of the dramatic growth of specialty pharmaceuticals, the biologics, if you're familiar with those. Those are medications like Enbrel or Humira. They're typically $22,000 medications for 12 weeks of injection, so a much lower cost solution to topical psoriasis or palmar plantar psoriasis, if cost control is one of our overall goals as citizens of this country. In addition, many major payers have told us that there are several problems related to E1399 and all the gyrations that they have to go through in terms of trying to utilize those codes for payment. We have many contracts where E1399 is attempted to be used, but there's a lot of effort that goes on involved in that, and that's given the numbers, it's not, I think, the appropriate use of E1399 overall. So I'd like to open up to questions related to our desire for obtaining a new HCPCS code for a multi-directional, larger than 2 square foot unit for the treatments of palmar plantar psoriasis of the hands and the feet. Thank you very much. Yeah, thank you. Just to give a sense, the unit actually does have lamps on the top as well. So it's important to know it's not just multi-directional. The panels, the reason that can't be used typically as a hand-foot device is because the ultraviolet light will come through and do additional exposure to an individual's face. So a multi-directional unit not only has a hood that protects the ultraviolet energy from going through, but it also will have a set of lamps that will treat the top of the patient's hands, and or feet. And again, as we talked about with the example, anatomically, it's impossible to treat the tops of the feet without having lamps in a multi-directional way on top, exactly like EO 694. Okay. Thank you.
I have a question.
Sure. Sure.
You are talking about the dorsum of the foot. How do you treat there with that particular machine?
I'm sorry, I didn't.
Dorsum of the foot.
The dorsal of the foot? The dorsal foot is not usually involved, but it's usually the top and the bottom. There is some reflective quality inside here. There are reflectors, as you can see, so the lamp is bouncing around inside. But the tops and the bottoms are how we're doing this. Our competitors may sometimes have a different version of that, but we're treating this with the lamps on the top as well as the lamps on the bottom.
Okay, thank you.
Mm-hmm.
I'm not sure I'm understanding here. You suggesting that people put their hands in there or their feet
Correct.
in there?
Correct. I should have clarified. The picture that we have in the presentation actually is 2 units.
Yes.
So if a patient would have hand and feet involvement, and that's pretty common, quite honestly, they would get 1 unit, and then they would adjust the unit based on height and put their hands as maybe a first exposure, and then they would put their feet as a secondary exposure. So a single unit is involved and is part of the code.
So your recommended code language, is it for the hooded device or the other device?
The hooded device. Because this would be not considered a multi-directional, it's a planar device, a single plane, if you would.
Oh, that's just a sample of a different device.
That's correct. That's more of a sample of an EO 691, which had been traditionally talked about as being a 2-foot panel. That is a 2-foot panel.
Then what's this foot component in your picture of your hand-foot unit?
That's another variation of a product that we sell as well.
But that doesn't have a hood.
It does have a hood, with all due respect. Yeah. Yeah, it's probably not a very good picture, but... it doesn't
really show the hood part so that you can see their hands.
So in this picture, I'm sorry, you can see
okay. Let's see if I can bring it up here. So see a bigger picture of it, maybe. Okay.
Yeah. Which component of that is your proposed code
Yeah, at the top unit.
intended to describe?
Yeah.
Just the top
Yep,
unit?
the top unit, correct.
What about the bottom unit?
Well, the bottom in this setup, this is actually more of a medical office setup. They're protecting the patient by that particular cabinet that physician has had. So the top unit is much more representative. It's a good point. I've never actually noticed that didn't have a hood on the bottom. But you can see that she's protected because there's a ledge in terms of that shelf that the ultraviolet energy is not coming through. The purpose of the hood is to prevent the ultraviolet energy from coming through and hitting the face.
So how do people not burn themselves on those bulbs in there?
Well, because it's a prescribed exposure, the physician will usually detail based on skin type where to start with. And there's also a wire. In this case, this has a plexiglass shield. The other product in the picture actually has a wire grid that sits on top of the lamps. But they are actually cool, even though they're emitting ultraviolet energy. It actually is a cool bulb, just like a fluorescent bulb, if you would.
So is the idea to put one of these in a person's home?
That's absolutely correct. And it's been done for about the last 5 or 6 years. It's been a prescribed item, of course, and it is absolutely going in someone's home.
So they don't have to go to the office?
Yeah. Just to clarify, one of the challenges to the treatment is to have to go 3 times a week for it's a chronic disease, so oftentimes for the rest of their life. So they're able to treat much more cost effectively in the home than have to go to a clinic or an outpatient care center. Yeah.
Rental or purchase?
Purchase. It's routinely purchased.
And how many treatments a week, say?
Excellent question. 3 times a week seems to be the standard protocol that's been established. Mm-hmm. Okay, thank you very much. Thank you to the committee.
Agenda item number 13, attachment number 14.96, request to establish a new Level 2 HCPCS code to identify a non-invasive open ventilation portable ventilator system, trade name Breathe Technologies Ventilator, and to discontinue code E1352. Primary speaker is Dr. Neil McIntyre.
Thank you very much for the opportunity to discuss this novel device. I'm Neil McIntyre. I'm a professor of medicine at Duke University. I've been involved in respiratory life support systems most of my career. I also serve as a consultant to Breathe Technology, who is developing this device, and have participated in the clinical trials and clinical trial designs. So the device we're talking about is a wearable ventilator, a device patients can actually put on their belt and allows them to ambulate better, do more functions better, because the machine is assisting their ventilation. It's a relatively small device, as I say. It can fit on the belt. It improves ventilation. It reduces shortness of breath, improves oxygenation, unloads respiratory muscles, and increases exercise tolerance. And again, a picture of the device, and we will show it to you a little bit later. The way it works is it has a nasal setup and senses the beginning of a patient effort. And once that effort begins, the machine activates and delivers pressure and volume into the patient's lungs. So again, here is the device that does the controlling, the ventilator. Here is the nasal interface. And this is a little graphic showing that the patient effort is only a small part of the actual gas delivery. The ventilator is providing the bulk of gas delivery into the lung. This is what a ventilator is. The FDA has long recognized this as a mechanical ventilator, dating back to July of 2009. It has gone through several iterations. It has been coupled to both oxygen and air compressed gas systems. And again, it recognizes the fact that this device can provide gas into the lung to provide ventilatory support. The problem that has developed is that CMS, unfortunately, has not recognized it as a ventilator. CMS instead has recognized it as an oxygen accessory. And because of this, there is considerable difficulty in getting appropriate payment for this, because as an oxygen accessory, it is linked to a bundled oxygen payment. So specifically, this device, they say, is not considered a ventilator, and suppliers must not use codes attached to ventilators and other positive pressure devices to bill for this particular device. And this is, as I say, a gross misunderstanding of what this device actually is. So I think it would be important for us to take a moment to review exactly what is a ventilator and what is an oxygen accessory, because they are two fundamentally different things. Ventilation, in physiologic terms, is the delivery of fresh gas into the lung. You and I sitting here in the room, we are taking in approximately 5 to 6 milliliters per kilogram. That is to say, if you were an average 70-kilogram person, you would be taking in with every breath somewhere in the neighborhood of around 400 milliliters. That is ventilation, 400 milliliters of fresh gas going into the lung. Oxygenation is a different process. Oxygenation is the movement of gas once it is in the lung into the bloodstream, an entirely different process. By definition, a ventilator is a device that will generate pressure to offload muscles. You and I get this 400 mLs by contracting our ventilatory muscles. This machine provides pressure to allow that gas movement to take place with little patient effort. I would point out that all ventilators need a compressed gas source. One of the things that CMS commented on when they originally classified this device is that it required compressed oxygen. Well, in fact, every ventilator on the market requires compressed gas. I rounded on the intensive care unit at Duke yesterday. I had 14 patients on mechanical ventilators, life support systems recognized by everyone as ventilators. All 14 were being powered by compressed oxygen out of our wall sources. So the mere fact that it uses compressed oxygen does not differentiate a ventilator from an accessory. An oxygen accessory only can enrich the oxygen that is in the gas. Here at sea level, well, actually, the atmosphere entirely is 21% oxygen. At sea level, that translates to about 150 millimeters of mercury. Oxygen delivery systems, oxygen accessories, oxygen devices, all they can do is increase that concentration from 21%, and they can go all the way up to 100%. But by definition, they do not provide energy to deliver that gas into the lung. Only a ventilator does that. So ventilation moves gas in and out of the lung. Oxygen and oxygen devices simply enrich the percentage of oxygen in that gas, but provides no pressure to deliver that gas into the lung. I would point out, of course, that oxygen and ventilators, oxygen accessories and ventilators often are used together. As I said, in my ICU, everyone on a ventilator right now is receiving oxygen. But they cannot substitute for each other. Enriching the oxygen will not provide positive pressure and delivery of gas into the lung. It just does, that's not what it does. And ventilation by itself does not increase the oxygen concentration in the gas. Two separate physiologic processes. This is shown graphically right here. This is pressure, and right here, the patient makes an effort. Starts to take an effort in. This device, the non-invasive open ventilator system, immediately delivers pressure into the lung, delivers volume into the lung, functions as a ventilator. The breath is delivered, the patient exhales, another effort, another breath. And I want to distinguish that from just breathing supplemental oxygen, where no pressure is supplied. The patient has to do all of the work of breathing. And again, an oxygen accessory is not providing ventilation. It simply enriches oxygen. Here's what's called a high-flow oxygen system, and still, despite a patient effort, no positive pressure, no gas delivery is occurring. In contrast, this ventilator is delivering pressure at the onset of patient effort to deliver gas into the lung. And finally, the predicate device, which is an intensive care unit ventilator, the LTV, is shown here in orange, and our device, the NIOV device, is in blue, and as you can see, they are behaving exactly the same. That is the reason this was a predicate device. Then the FDA recognized it as such and approved our device as a ventilator. A ventilator. This concept has been recognized by numerous organizations, professional organizations, patient advocacy organizations. They recognize that this ability to unload respiratory muscles is an important and distinct function and will allow patients' muscles to be unloaded and improve function. There have been a number of studies, clinical studies, a number of abstracts showing increasing in walk, increasing in comfort, reduction in shortness of breath. respiratory mechanics are made better, and although the studies are small, it looks like we can even, with this kind of improved mobility and function, reduce hospitalizations. Again, a number of abstracts have also reported these clinical findings. One of the best studies that has been done was Dr. Casaburi looking at 10 patients with severe respiratory failure. This is just looking at how long they could exercise on room air. He supplemented the oxygen and they improved somewhat, but only when he was able to provide the ventilatory support in addition to the oxygen supplementation did he get a very substantial improvement in function. And Dr. Casaburi went on to look at muscle function. This is muscle activity. As you can see at baseline, a lot of muscle activity. With oxygen, it's reduced. With our device, it is dramatically reduced. And these are just several different muscles. This is a dyspnea score, shortness of breath score, showing considerable improvement. This is a measurement of oxygenation. And this is a measurement of heart rate, which is an index of cardiac stress, all of which are improved somewhat by improving the concentration of oxygen, but nowhere nearly as much as if you actually take this oxygen-enriched gas and combine it with a ventilator to deliver it into the lungs and unload the respiratory muscles. We have done some usage surveys with this device as well, looking at a number of clinical endpoints. Scores on dyspnea consistently become reduced, indicating patients feel better with the device. And cost reductions are impressive. Before the device, after the device, looking at things like ER visits, inpatient days, ICU days, ventilator days, rehab days, all of which are dramatically improved. So what we're trying to do here today is treat this device for what it is, a ventilator. It is not an oxygen accessory. Yes, it uses oxygen, but it does so much more. It actually takes this oxygen-enriched gas and physically delivers it into the lungs to unload respiratory muscles, reduce the patient's work of breathing, and increase what they can do with it. As I tried to show you briefly, there are some economic benefits, patient advocacy benefits. The patients who are going to use this are not a huge number, but they're real and they are important. And I think it's critically important, and the thrust of our argument here this afternoon with you, is that we've got to rescind this designation that this device is a simple oxygen accessory. That's a fundamental misunderstanding of what this device actually is, how it works, and the physiology involved with ventilation versus oxygen enrichment. We are asking for appropriate coding, appropriate coverage, and appropriate payment. I will stop there, and I believe we have two 5-minute speakers to hopefully enhance my comments.
Okay, our first 5-minute speaker is Annette Sullivan. Okay, where should you be? Okay. Our first speaker is Larry Mastrovic.
Thank you, Dr. McIntyre. Hello, everybody from the committee. Just to reiterate a number of things that Dr. McIntyre has said, it's a wearable. I'm sorry, I'm Larry Mastrovic. I'm the president and CEO of Breathe Technologies. Absolutely. Wanted to spend some time here talking to you about a few things and to reiterate a number of the issues that have been brought up today. And I have the device here. I wanted to let you all take a look at it. As we said, it's 1 pound. It's easily portable. It's very wearable. Patients have an easy time being able to manipulate it. There's only 3 settings on it. The settings are medium, low, and high. They have the ability to, you can turn it on. They have the ability to change those settings depending on their individual activity level. So we do give them some control over their lives and what they're able to use this for. So a number of things that have happened since we have been in business and been working towards trying to finalize a code. A long, arduous road. I'm sure that you all are familiar with that. You're sitting through these meetings on a yearly basis. We have filed for, back in 2012, went to the PDAC and just asked for a coding verification. And we were given a coding verification of an E1399. We spent the entire year of 2013 using that code. I would reference the last speaker who talked about how difficult it is in order to use an E1399, but I would tell you it's much more difficult to use a code that has no reimbursement and is bundled with something else, which is nearly impossible to work with that. So we had over 200 patients that had been put on the device in 2012 and 13, paid for by the Blues, many of the Blues in the Northeast. It was Independence Blue Cross, Horizon Blue Cross, Keystone Health Plan East, Kaiser has paid for this, United Healthcare, Aetna, and we've had a number of VAs that have purchased the device for patients. So it's an inpatient and an outpatient device. The 200 have been between the inpatient and outpatients, about 10% inpatient, 90% outpatient. So where we are today is we cannot get paid for the device. We, not us, the provider who's providing it, cannot get paid because of the E1352 code, that there is no reimbursement. So to date, Medicare has not paid for one patient that's had the device. And what's happening is that because of that, you have a very limited access point for patients that would require this. And you can see that from some of the clinical data that we've been able to present, that we have had tremendous results with patients being able to use this device and staying out of the hospital, staying at home, giving a break to their caregivers. There's a lot of work that goes into a patient that has a number of issues that they would have these complications and would benefit from this device. So there's been an economic study. The one thing that Dr. McIntyre pointed out was when you look at that study, we've only had 6 patients through it. We only have about 20 patients that are in the study. Quarter of the way through, we show a 90% reduction in spend inpatient and outpatient with before and after using the device. Very significant thing to recognize today. Healthcare costs continue to go up. We're all taxpayers. We're all looking for new opportunities to find ways to be able to lower costs and provide better care. This is a device that has demonstrated that in a number of settings and in a number of ways. So we really would encourage you to think about how this is being coded and how it's being used and how it's been miscoded and how we would like to have it rescinded. The code that we have out there today does not represent the device, does not represent the population that would require the device, and we have asked to have it rescinded, and we were asking to have an appropriate code defined for this device as we go forward. So we've filed an application for that. So we've got a code without even asking for it, so I'd like to ask for you to rescind the code that we're asking you to do that now. So that was a very convoluted process that we went through, not even sure how it happened. We had no application. We filed for no application to have this done, and we ended up with a code, lo and behold, to us. So a number of things have happened since then. The biggest issue we've got right now is because we have this code that sits there with the E1352, we are not able to sell it. It's very difficult to get anybody to pay for it, and if we're selling it privately. Any questions? I'd be more than happy to answer them. And then we've got Dr. Lamberti as well. Did you want to?
I have a question on, so do patients do patients sometimes transition from using this to oxygen?
Actually, it's often the other way around, because we've never had a device like this before. We have patients who are usually this is right now designed for the outpatient arena, often in pulmonary rehabilitation facilities. These patients are debilitated by their lung function, and up till now, all we've been able to do is simply supplement the oxygen concentration of the gas they breathe, and that can provide some benefit. This is the first time we have actually had access to a device that not only can deliver enriched gas, but can deliver it under pressure to actually affect ventilation, gas delivery into and out of the lung without the patient's muscles having to do it. So this is it's a novel device, and it doesn't, as I say, we've never had anything like this before, and at the moment, we are transitioning outpatients who are severely debilitated. Almost all of them are already on oxygen supplementation, but now we're finding with this additional benefit of ventilation and muscle unloading, we are able to improve their function quite dramatically. So it's an outpatient device right now for home rehab facilities, places like that.
And how long does a patient continue to use this? As long as a year or
This is the kind of lung disease, once you've optimized the medicine, you're kind of stuck with it. You can push the medicines as much as you can, try to open up their airways, relieve their sense of dyspnea as best you can, provide oxygen as best you can. But these stiff lungs, these lungs with narrow airways, put a lot of workload on your respiratory muscles. And as a consequence, these patients are limited. Now we've got a device that will put positive pressure into the lung, push the lungs open. The ventilatory muscles don't have to work as hard, and therefore they can function more. And it's going to be a lifelong phenomenon, I would think, for most of these patients. Even if they get better, they're going to, at least our experience has been, they don't want to give it up. It helps them move around better.
So are there different models that they test or try for any trial period?
So this device is the one that we have. This is what they test or trial. So we have a 6-minute walk that each patient goes through. So what they are using is a 6-minute walk to start on their oxygen. Then we measure the distance. We also look at their heart rate, their oxygenation score, and we look at how long they can walk, the time frame that they're walking in. We put them on the device. After that, we record all those scores, and then we do the same test all over again. And what we see is a difference of about 50% in their dyspnea score, so the Borg score drops. Their oxygenation typically goes up between 8 and 10%. Their heart rate drops around 10%, and they typically get about another 70 to 100 meters longer that they can walk in the 6-minute walk. And they can typically go for the full time. The patients that really you can see the benefit of them, they're the ones that can talk while they're actually walking. So if you've not seen a patient with lung disease and ever tried to have a conversation with them when they're walking, it's nearly impossible. When these patients are in their full gallop when they're on this, they're talking. So it's a completely different experience for them because of what Dr. McIntyre was explaining, the ability for the pressure and the volume to be driven into their lungs, and you're driving the gas deeper into the lungs, so they're getting better gas exchange.
We were talking about this earlier, and we commented that this clearly is a ventilator. It is not an oxygen it's not an oxygen accessory. And if someone says, well, it's not a portable ventilator, what on earth would a portable ventilator look like then? This is a portable ventilator.
Is this used for 24 hours of the day?
We've looked at, it can be. We've looked at patients that are using this primarily for ambulation. Okay. So average use is between 6 to 10 hours a day.
Can the patient increase or decrease the pressure?
Yes. There's 3 settings. It's
those
medium, low, high. These 3 buttons allow them to be able to increase it or decrease it depending on their activity level.
Okay. Thank you.
We have one more speaker, so if you wanted to ask your question or... Okay.
Our second 5-minute speaker is Dr. James Lamberti.
Thank you. I'm Dr. James Lamberti. I'm a pulmonary specialist in Northern Virginia. I'm a clinical professor of medicine at the Virginia Commonwealth University School of Medicine, and I am the medical director of respiratory care services at Inova Fairfax Hospital. I have no relationships, financial or otherwise, with Breathe Technology or any other device manufacturer. I am representing the National Association for Medical Direction of Respiratory Care, NAMDARC, for which I am a board member. Our organization has physician members that utilize mechanical ventilation and oxygen therapy on a daily basis. As Dr. McIntyre alluded to, yesterday, my respiratory therapy department had 78 individuals on mechanical ventilation. We are the experts in mechanical ventilation and the delivery of oxygen to patients with respiratory diseases. NAMDARC has submitted written comments to this work group, but I really would like to highlight some of the comments a little bit further. First of all, the decision to classify this device as a oxygen accessory device really seems to NAMDARC to be outside the usual transparent process that usually occurs when new codes are described. NAMDARC was not consulted, and neither were either of the large pulmonary organizations, the American Thoracic Society or the American College of Chest Physicians, that really represent pulmonary medicine. The board of directors of NAMDARC believe unequivocally that this device is a ventilator. We spoke about this, we reviewed all the clinical studies, we reviewed the technical data, and in our mind, this is a ventilator. If the concern that CMS has is the coverage criteria, and I think that is valid, it's an organization like NAMDARC that CMS should come to. We have a history. About 15 years ago, NAMDARC helped CMS establish the criteria for respiratory assist devices, which stands currently in place. But as a clinician, I would like to spend a little bit of time just so everybody understands what group of patients we're talking about and what we're trying to accomplish here. As Dr. McIntyre alluded to, it's really patients with end-stage lung disease, and frankly, most of those patients are Medicare beneficiary age. They usually have COPD, some have interstitial lung diseases like pulmonary fibrosis. But a small but significant proportion of these patients remain short of breath, despite our best efforts of oxygen therapy and drug therapy. And you may have seen these patients. These are the patients that you'll see maybe at the grocery store or at church, either with their oxygen slung over their shoulder, huffing and puffing to get from the handicapped parking spot into the grocery store or church. These are the individuals that we are trying to make a difference with. And what I would like to compare is patients with severe COPD to patients with severe congestive heart failure. As you guys may understand, about 20 years ago, left ventricular assist devices came into the market. I remember those. They were about the size of a desk. They were external to the patients. We only used them in hospitals. Left ventricular assist devices are now portable, implantable, and have made an amazing difference for patients with end-stage heart disease. So in summary, NAMDARC believes unequivocally that this NIAV device is a ventilator. We stand available to this working group and CMS to assist if what the problem is coverage guidelines. But the CMS classification decision has significant clinical consequences. Patients with severe COPD, severe interstitial lung disease will be neglected in regards to their ability to do functional activities throughout the day. But even more importantly, NAMDARC is concerned that a decision like this will put a halt to the technological advances that can occur going forward in mechanical ventilation. I would like to thank this group for your consideration. Thanks.
Questions? Okay. When Ms. Hake spoke at the very beginning, she identified that there are times when a HCPCS code is developed, deleted, based on a program operating need for the agency or an insurer. The code was requested by the 4 DME MACs and submitted as a program operating need to CMS. That program operating need was related to CMS, and the code was established to identify the product that we're discussing right now. So there wasn't anything underhanded. I believe the 4 DME MAC medical directors have been in contact with you over the last year and have been in discussions with NAMDARC as well. Is that not correct?
That is inaccurate. We had conversations with the 3 medical directors in 2012. We only got to speak to 3 of them because the 4th one did not want to talk to us. So we had a conversation with the 3 of them, and we had gone through a number of ways of trying to explain to them what this device was. We had filed an application with the PDAC in 2012, and all we were looking for was coverage verification at that time. And what we had received was an E1399. And at that time, we thought we were working towards the device being considered as a respiratory assist device. We were all the way up to the 11th hour with that in November, and we were never contacted. We received the bulletin when it was launched with the rest of the world that said that the device was an oxygen accessory and it would be considered as an E1399. We had then had numbers of conversations with specific medical directors trying to make them understand where we were with this process. There was a couple of meetings that did take place. We never filed for a code. We never asked for a code. We had meetings just discussing the issues. It was on their behalf that they took under their own consideration to come up with this code, with meeting with one or two of the physicians that they talked to, but never listened to any of the data or any of the clinical arguments. So we feel like this process never should have happened the way it did, because there was never a commentary period. There was never a hearing like we're at today. And there was never any time that there was a public way of being able to get the medical societies or the clinicians that you're hearing today to be involved in that. So I think we did go through a convoluted process. And we have finally filed an application in 2013 for 2014 to have the code rescinded and to have a new code or a code looked at that's appropriate for this device. So what we're asking for, the ask is take us out of the books on the E1352 code. I'd rather have no code than to have that code, because it doesn't preclude us from being in the marketplace. This code precludes us from being in the marketplace.
This from the medical community, this code is extraordinarily difficult for us to understand, because as I tried to explain, it seems to misunderstand or miscategorize what is oxygen supplementation and what is a ventilator. Two fundamentally different processes, two fundamentally different types of devices. And to take a device that all of us in the medical community and the FDA agrees is a ventilator and defining it as not a ventilator but simply an oxygen device, I think shows some, I don't know how to say this, misunderstanding of what oxygen supplementation and what ventilation actually is. They are two different things, and this coding seems to miss that critically important point.
And I'll speak for NAMDARC because 15 years ago we were involved with CMS in setting up the RAD guidelines. We welcome that kind of interaction. We have not had that interaction with the DME medical directors. We've had the ability to send them our thoughts. There has been no reply, no ongoing discourse that helps us to get any further in the appropriate understanding that this is a ventilator.
Thank you. Agenda item number 14, attachment number 14.95. Request to establish a new level 2 HCPCS code to identify a device that changes insulin delivery in response to a patient's condition. Trade name, MiniMed 530G with Enlight. Primary speaker is Dr. Francine Kaufman.
Good afternoon, and thank you for the opportunity to be here today. My name is Dr. Francine Kaufman. I am an employee of Medtronic Diabetes as their Chief Medical Officer and also representing Medtronic Diabetes today, who is the manufacturer of the MiniMed 530G system with Enlight. And this is first of its kind artificial pancreas system that is designed with an automated feature to actually stop insulin delivery at the time of a hypoglycemic threshold, a low glucose threshold. It was designed to mitigate hypoglycemia, which remains a significant problem for people with diabetes, in that it can cause them to become confused, disoriented, have a convulsion, enter a coma, or even die. So I want to start with, again, this is a artificial pancreas system, and in January, we asked for the HCPCS Workgroup to establish a new code for this new system, this artificial pancreas device system, external with insulin, and again, this is the MiniMed 530G system with Enlight. I want to talk a little bit about the data that we have developed that shows how this system functions. First of all, it received FDA approval in September of 2013, and the system involves an insulin pump, as you can see here, and a glucose sensor, and this pump has automation so that when the sensor sends a signal of a low glucose level, the pump automatically stops insulin delivery. Basic physiology would be that you do not want to give somebody insulin when their glucose value is low. Glucose lowers, insulin lowers the glucose value, so you would like to remove insulin at that point in time. And this is the first system that does it automatically. This shows the schema of actually how this works. So here's a tracing of a sensor glucose value. It's in the target range. It hits this low threshold, and whether or not the patient is awake or alert, it will automatically stop insulin delivery. At that point, if the patient is awake and alert and wants to treat their impending low glucose value with an oral glucose supplement, they are capable of doing that. They can hit a button and restart insulin delivery. But if they're sleeping through their hypoglycemia, if perhaps they're confused from their hypoglycemia or don't respond, then the system will shut off insulin delivery for 2 hours, during which time it is likely that the glucose value will fully recover. We've run into a little snag in some literature that has been written about this. It's called low glucose suspend, or LGS. And in our system, we call it threshold suspend, or TS. Again, here's what the system looks like, and you can see that the sensor, which is placed in the subcutaneous tissue, measuring glucose continuously, sends over a signal to the pump. And the software in the pump, this added feature that has not been in an insulin pump before, that makes it completely different than all insulin delivery devices that are available up until this point in time, has software that will stop insulin delivery to allow the patient to recover from hypoglycemia. Here's a schema. This can either be on or off. There's a range of thresholds that it can stop insulin delivery at that's usually set between the patient and their healthcare provider. And here's the schema. So it hits this, it stops insulin delivery, the glucose value recovers, and 2 hours later, insulin delivery can resume. So we've had the opportunity to do a number of studies from a Medtronic sponsorship standpoint, as well have there been a large number of studies done by outside investigators. This study was called our Aspire in-home trial, and it was a randomized control trial that lasted for 3 months with a large number of patients who are randomized to either a pump, a conventional pump, and a glucose sensor, or the 530G with Enlight system that has the threshold suspend feature to automatically stop insulin delivery. The outcomes are what we call area under the curve, that looks at how much time and what's the lowest points of the glucose value that actually relates to the overall exposure to hypoglycemia. The other outcome measure is called an A1C, and this is a measure of the average glucose value, and the hope is that as we remove more and more hypoglycemia, we don't overall deteriorate glucose control, and that the A1C value does not increase. This is an example of how the study was enrolled. So there was a run-in period, a randomization to the control group, which was a conventional pump and a glucose sensor versus the threshold suspend feature, and then we looked at the outcomes at 3 months, and you can see that the two groups are essentially the same at the time of the randomization procedure. The results showed, and here's the threshold suspend group at baseline, and then after 3 months, here's a control group baseline, and after 3 months, and comparing the 2 3-month time periods, there was a 37% reduction in this area under the curve, or the overall exposure to hypoglycemia for the patients. This is looking at actually the number of events of hypoglycemia per patient week, and we're looking at night and over the full 24-hour time period, and again the threshold suspend MiniMed system compared to the control, and you can see that there was a reduction in the number of events of hypoglycemia at night as well as during the entire 24-hour period in the range of about 30%. This graph shows the overall percent of sensor glucose values that were less than the 70 milligram per deciliter, which is the threshold. Anything underneath is considered hypoglycemia. And you can see that when we look at night, and again for the full 24-hour time period, cut by less than 50, between 50 and 60, less between 60 and 70. So overall, less than 70 milligrams per deciliter. There's a significant difference between the device with a threshold suspend feature and the control group, and now in the 40% range difference in the amount of just sensor glucose values that are in the hypoglycemic range. And then this is the outcome measure that's considered the safety outcome measure, looking at the overall average glucose control, and there's really no difference. So at the end of 3 months for the threshold suspend, there was no deterioration of overall glycemia, so we were able to improve that hypoglycemic exposure without meaning that we have more hyperglycemia on the other end, but in fact that the range was moved up into the desired range for glucose values. This was also done with no episodes of diabetic ketoacidosis in either group during our study. Lots of literature has been written about the threshold suspend feature. Sometimes it's called the LGS feature in these reports. They've come from Europe, from Australia, from inside the United States, and they all essentially show the same thing, that we're able to reduce the duration, the depth of hypoglycemia, and not end up with an increase in hyperglycemia as a result. This slide shows that we are able to actually look at those who have purchased the device, who are wearing the device, and who are uploading into our CareLink data management system, which is a voluntary thing for them to do, and they sign a consent that when they enter that allows us to look anonymously at the data. We're now up to about 140,000 patients that we've looked at, with over 1 million events of this suspending of insulin delivery. But this is just to show, when we looked at the first 5,000 patients, this is the number of events that they had, those that lasted the full 2 hours. And it's exactly the same in the real world performance of this device compared to the performance that we saw in our Aspire study. A reduction in those values less than 50, no change or increase in the values greater than 300, and no real significant change in the A1C value either. So real world performance acting just like our randomized control trial performance. And when we line up, what does this actually look like when we look at these events that last the full 2 hours? So the concept is the patient has not interacted with the device at all during this time period. We can see that they've not pressed any buttons, and the device itself is doing all the recovery from hypoglycemia. So they're coming from a normal glucose, they trend down, they hit that threshold, they shut off, and then they normalize their glucose at about the 1 hour time period. But by 30 minutes, 20 minutes, we already start to see the inflection on the way up. And this curve from the real life experience from our CareLink database looks the same as from our controlled randomized trial. We had the opportunity to do another trial. Matter of fact, this was a pivotal trial that allowed for FDA approval of the device. And what we did is we took 50 subjects and induced hypoglycemia in them by exercise and fasting, and then watched their glucose values decrease to the 70 milligrams per deciliter. And this is when what happens now with somebody who has diabetes, who's not using this system, they will continue to get basal insulin from their pump. If they're taking shots, they've already got insulin inside their body that cannot be taken away, and as a result, they remain hypoglycemic for hours after hypoglycemia has been induced in this fashion. When we do it again in the same population, and obviously random order, we now see that when we stop insulin, when they hit the 70 threshold, they have the opportunity to recover by an hour. They're on their way significantly to recovering their glucose value, and they end up at the end of the 2-hour period with a glucose value, for the most part, within the normal range. This is to show that same curve from another study. This is a large study that was done in Australia, lasting 6 months, and again, the same kind of curve that we see. However, this device is used in clinical practice and randomized control trials, in ones that last even a longer time than 3 months. This lasted 6 months. The same kind of, you hit the threshold, you get a recovery. At about 30 minutes, you start to see increasing glucose values, and by the end of the full 2-hour shut off of insulin, you're back into a glucose value in the normal range. And this is looking at that same study done in Australia, looking at episodes of moderate or severe hypoglycemia, and they compared it to, during the 6-month time period, the comparator was just pump therapy alone, and they had no severe hypoglycemic episodes compared to what happened with pump therapy alone. The way it is now, the same number that they saw in the baseline study time period. This is looking at their glucose data at 6 months, and this is daytime, this is nighttime. Here's the baseline for the pump alone and the LGS, or the threshold suspend device, and you can see that at the 6-month time period, there's a reduction in the amount of hypoglycemia at day as well as at night during this longer study. So let me get to what we're here really to discuss today. And that is looking at the existing code, the E0784, which is an external ambulatory infusion pump using insulin. And we feel that this is inadequate to describe the device that is the 530G with Enlight system. We do respectively disagree with your preliminary decision. We note that when it was given to us, there was truly no explanation as to how it was derived. We have, I think, identified how the artificial pancreas system is really clinically and functionally different from the devices of the past. The standard insulin pump that has no automated feature, that just has the ability to give pre-programmed insulin regardless of what's happening to somebody's glucose value. The artificial pancreas system, we feel, meets all the criteria to add a permanent HCPCS code, and the recent decision to create S codes for the private payers for the artificial pancreas device system gives clear evidence that E0784 does not adequately describe this device. So we feel that we've met the criteria, the Tier 1 as well as the Tier 2 criteria, and that I think I've gone over all of these points, but I'll quickly go over them again. That first of all, this has been FDA approved. Multiple payers have been operating with supplying this device, and it is really out there in ever-increasing numbers in the diabetes population within the United States. The E0784 does not recognize the distinctions between this system and the code that was given 18 years ago. And we also feel that this really is a different system. It's the first artificial pancreas. This was defined actually by the FDA, and the first system to respond automatically from a sensor glucose data point to changing the delivery of insulin by the infusion system itself. So the S codes, the multiple private payers have already acknowledged that this is an artificial pancreas system and that it is distinct from conventional insulin pump therapy. And as a result of this, unique HCPCS codes were created effective July 1st, 2014. And here's a listing of those S codes that were developed to describe the artificial pancreas device system and its components. So in conclusion, the artificial pancreas system we feel meets all the criteria for a new permanent HCPCS code, and that the old HCPCS code of over 18 years does not acknowledge this really is an ongoing true advancement of diabetes technology. Private payers have recognized the distinction between the conventional pump and this artificial pancreas system, and there are ever increasing numbers of patients using it across the country. So okay, thank you. Thank you very much. Okay, are there any questions?
I just have one question. Many of your slides had indicated that the studies were done on devices that were not FDA approved nor for sale in the U.S. And then your other analysis was only done by Medtronic internal analysis. Are there new studies of this device that is approved?
So the system that was used for these studies is the same pump. It's the same automated software. The difference between what was used, so the Veo pump, which is sold outside the U.S., has only two differences between it and what's sold inside the U.S. One is the amount of insulin that can be delivered in a bolus that the patient actually does themselves. And outside the U.S., you can give 75 units. Inside the U.S., the FDA required that we only give 25 units, so that has actually nothing to do with the automation. And the other is that outside the U.S., you can automatically calibrate the sensor, and inside the U.S., you have to press a button to automatically calibrate the sensor. So they're really the same devices. They look exactly the same. They come off the same manufacturing line, except for those two differences. Okay, thank you.
Agenda item number 15, attachment 14.93, a fifth request to establish a new level 2 HCPCS code to identify a portable knee extension device. Trade name Elite Seat. Primary speaker is Michelle Goldner.
Good afternoon. My name is Michelle Goldner. I am the Director of Business Development for Kneeborn Therapeutic, LLC from Indianapolis, Indiana. And I have no personal financial connection to this company other than as a paid employee. But I have a quick question for everybody before I get started. How many of the people in the room, by a show of hands, have experienced knee pain at some point in their lives? Okay. One, two, all right, come on. Everybody's had knee pain. Anyway, the bottom line is you're not alone. And we set out to help individuals with knee pain. And to that end, we respectfully disagree with how we have been currently classified with the HCPCS codes, specifically E1811. So as the Director of Business Development, my team and I work with doctors all over the country on a regular basis who are very frustrated because they recognize this new technology, the Elite Seat, but their patients are having a very hard time qualifying for coverage. And this is a common theme that we've heard throughout the afternoon today. The Elite Seat is now described in code E1811, but that's very vague. It allows this product to be interpreted subjectively by insurance providers, and it does not fully describe how this product provides its therapy. No part of the current E1811 code adequately describes the design, the therapeutic value, the intended function, or even the correct pricing and reimbursement of the Elite Seat. And that's what I'd like to go through with you this afternoon. So let's talk a little bit about what the Elite Seat is. It is a non-static knee stretch device that is safe. It's been proven through clinical peer-reviewed studies. It has a single purpose, and importantly, it is not a capped rental item. So this clearly excludes it from the definition of the code E1811, which is defined as a static progressive stretch knee device, extension and or flexion, with or without range of motion adjustment, including all components and accessories. Okay? So let's break down specifically where the Elite Seat differs from other devices categorized under E1811. Static in this category means that the patient goes through a therapy protocol, but nothing about the setting of a static stretch device changes. So what this means is the configuration of the device is set, the patient is put into the device for the allotted time of the therapy, and at the end the device is removed. That's it. Nothing changes. The critical point to consider here is that the Elite Seat is adjusted throughout its therapy protocol, which averages 12 minutes, anywhere from 3 to 5 times per day. That adjustment is controlled by the patient's own individual tolerance level to achieve a full terminal knee extension. Plus, the Elite Seat is only used by the patient until that full knee extension has been achieved. Once the patient has achieved it, they're done. It does not address flexion of the knee. It is not worn for an extended period of time, nor is it a brace. So again, these are all the elements that we are using to define why we do not fit into E1811. The protocol using the Elite Seat is now fully accepted throughout the orthopedic community in the US and around the world, and is the first line of treatment of arthrofibrosis of the knee. As many of you may know, arthrofibrosis of the knee is the second most expensive treatment done in hospitals in the US today. So this is a big cost factor for patients and for providers. The Elite Seat provides a high-load, non-static stretch with an infinite load potential limited only by the design and strength of the device's components and the individual patient's tolerance to help achieve prescribed objectives. And again, you'll hear a recurring theme here. This is about the patient controlling, by their own tolerance for pain, the therapy to help them get that full knee extension. Another component of that E1811 code defines products in this category as capped rental items. And as you all know, that means that the device is rented and eventually it's owned by the patient for extended use over time. The Elite Seat is only used until the full terminal knee extension is achieved, and then it is returned. It was never ever meant to be purchased by a patient. It can be sold to clinics, but never by a patient. Okay? The Elite Seat can offer other benefits that many of the products in this category can't touch. This includes immediate results. After being in an Elite Seat one time, patients experience pain relief. Second, because the device is designed to be used at home, the costs and the need for multiple physical therapy visits are greatly diminished. The Elite Seat can help some patients avoid the surgical alternatives altogether. And finally, the short treatment protocols help with better patient compliance to achieve the therapy objectives. The obvious costs of time and money associated with other therapies such as serial casting, total knee replacement, manual manipulation under anesthesia, and arthroscopic procedures may also be avoided. Bottom line is that the Elite Seat offers patients an alternative that it's safe, it's proven, it has a single purpose, and it is not a capped rental item that they purchase and then at some point it ends up in a garage sale because they don't use it correctly or over the term that it's meant to be used. So let me see if I can catch up really quickly here. So let's talk a little bit about the surgical options. It's well known that anytime anyone goes under anesthesia for major surgery, they run the risk of complications and even death. It's a stated medical fact. We all sign a release that we understand that fact. But as a non-invasive alternative, the Elite Seat may help patients avoid the costs, the risks, the lengthy rehabilitation, and the recovery associated with these very drastic treatment methods. At minimum, if surgery is an option or is necessary, the Elite Seat can also be used both preoperatively and postoperatively to improve the outcomes for the patient. It helps by getting that knee extension. That patient goes into surgery stronger and better prepared, and when they come out of surgery, they can go into rehab more quickly and get through that process more quickly and more effectively. It results in more positive outcomes for patients. The American Academy of Orthopedic Surgeons has recognized and endorsed the Elite Seat treatment protocol as a first line of treatment for osteoarthritis. And again, it's been proven by numerous clinical peer-reviewed studies. There are textbooks that now point to the Elite Seat in their diagrams and examples as a way to approach therapy protocol. And so finally, let's talk about the almighty dollar, because it's very important in our day and age. The costs of healthcare as well as healthcare insurance are going up, and there are a number of people, despite the Obamacare plan, who still cannot afford costly surgeries and extended therapy. Then there are those people who are not surgical candidates at all. Let's talk about the 50-plus folks that might use the breathing apparatus and the oxygen delivery apparatus. They may not be able to go under the knife to have surgery. So what are the alternatives for these folks? Well, the alternative is the Elite Seat. We can help patients cut down the number of PT visits, experience fewer complications throughout the therapy process, and reduce both the inpatient and the outpatient treatments, resulting in significant savings to both private insurers as well as Medicare and Medicaid. So let's summarize. What is the Elite Seat? The Elite Seat is a non-static knee stretch device that is safe, it is proven, it has a single purpose, and it is not a capped rental item. Patients of all ages can benefit from the Elite Seat therapy protocol, but it's most important to remember that it really provides a viable alternative to those individuals who, for either financial or medical reasons, cannot endure surgery. And it is a way to shorten their rehabilitation and get them back mobile again. According to a survey of roughly 353,000 individuals done by Gallup Healthways Wellbeing Index in 2012, 47% of Americans suffer from chronic pain. Of the 47%, a third of those are specifically knee and leg pain. So there are a lot of people out there who are going to be candidates for some sort of knee therapy. The Elite Seat can be instrumental in improving the quality of life for patients. For anyone who's ever suffered knee pain, you know it's debilitating, it's intrusive, and it can greatly limit your quality of life. The Elite Seat, again, is safe, it's proven, therapy protocol, and it is a high-load, non-static treatment device for the knee. And that is what we would like the HCPCS code for this device to say. Thank you, and I appreciate your time. Any questions?
I have a couple questions. So I'm looking at your brochure, and thank you for sending that. Can you elaborate a little bit more about what is operating on this device and what is static and what is non-static on this device?
Do you want me to go ahead and take that, Annette? This is the president of our company, Annette Sullivan, and I will have her answer that for you specifically.
Thank you.
Could you repeat the question, please?
Sure. I'm just looking at your brochure here, and I'm trying to look at and understand what is static and what is non-static, or the movable parts on the device.
Actually, have you not seen the Elite Seat in motion before?
I haven't seen it physically, no.
Okay, I brought one with me, and we can put it up on the stage and show it to you if you'd like. That's what we're saying. We are a non-static progressive stretch, and it is basically a high load that pulls the knee down into extension. You have a strap that goes along the bottom of the leg and one along the top of the leg, and as you crank it, because it's connected to a cabling system, as you crank it, it pulls your leg down with a tension that comes from above. It's not a pneumatic, it's not a spring-loaded, it's all patient-controlled. And I'd love to show you the product.
Okay. I'll take a look at it after the...
Okay.
Yeah. And what is the average length of use?
It's about 10 to 12 minutes a session, 3 to 5 times a day. We typically see people use it probably twice a day.
And the duration?
For 60 days, roughly 60 days.
Roughly about 60 days. It's something that addresses the underlying issue with knee pain. Typically, people who have knee pain have developed a flexion contracture of the leg. This will help you get that extension back in, your range of motion back in, and typically your knee pain goes away. The reason we're here is we have a lot of physicians all across the country that are requesting, why can't we get this covered? Why can't we do something about it? And in your own state of Maryland, we have probably about 50 doctors that prescribe it. Walter Reed Memorial owns a unit. Orthopedics and Sports Medicine owns a unit. National Naval Medical Center owns a unit. Anne Arundel Medical Center owns a unit. The SEAL Team 6 owns 2 units. Your Baltimore Ravens own a unit. I mean, I could go on and on for some of the facilities that own it, but unfortunately, a physician will say, can this be covered? And, that's the difficult part, and that's what we're here for.
Well, and because this category describes things that are quote-unquote experimental, we're not experimental. It's been proven. There are clinical studies. It is written up in textbooks. There's no guesswork here anymore. And so therefore, the insurance, again, the vague description is allowing insurers to subjectively define what this product is. And we feel that the current HCPCS code is a mismatch. And we need a new code that talks about what this product is. It's high load. It's non-static.
I have a question. As you said, it is for 60 days they will use, right? Afterwards, what happens to that equipment?
It's returned back to the DME provider. It is a rental item. It's not
a rental
purchase.
item. Okay.
Correct.
Thanks. And another question is regarding the benefits. You have showed in your slide that they can avoid almost half of the surgeries related to the knee pain. And are there any studies your company has done or anybody has done? Studies saying that, okay, after using this particular type of...
I think the most compelling study that we have is the deconditioned knee study, which is done by Dr. Donald K. Shelbourne out of Indianapolis, Indiana. He's been here before. He's world renowned. His CV is about 85 pages long. I think if you look just about at any study that talks about the importance of extension, you'll see something that he has published and that is peer-reviewed that goes into that information.
There are randomized studies, randomized control studies?
Yes. This is the product that is used in the studies that have been done for range of motion. And I think, Cynthia, you have copies of a lot of those studies, and we can bring truckloads more. Okay.
Correct, right. Any other questions? Thank you for your time.
Thank you.
And as Annette mentioned, we do have an elite seat here if anyone wants to take a closer look at it.
So, Annette, you no longer need to speak? Okay, thank you. All right, this brings us to our final agenda item of today. It is item number 16, attachment number 14.97. Request to establish a new Level 2 HCPCS code to identify a portable, synchronized pneumatic compression device. Trade names Active Care Plus SFT and Active Care Plus DTX. Primary speaker is Dr. Michael Mont.
Thank you. Okay. So I want to thank the HCPCS Workgroup and I guess the CMS for listening to this presentation. First, to just introduce myself and I guess a little bit about why I'm here, about this product. I'm an associate professor at Johns Hopkins and I work at Sinai Hospital, Baltimore. I'm an orthopedist. I do about 700 hip and knee replacements per year. I like doing those, but I'm really about treating over 10,000 patients a year, trying to preserve their knees or hips. In fact, the center that I'm the director of is the Center of Joint Preservation. So we're about injections and braces and a lot of devices to save people from a hip or knee replacement, even lesser operative procedures that preserve cartilage. And that's what I'm always excited about. But unfortunately, a lot of patients do need joint replacements. And we're going to talk about a device that prevents blood clots in patients that get a hip or knee replacement. And we're going to talk about a device that I think is vastly different than what's out in the field. That deserves its own code. The device is what you can see there. It's a battery-operated device. It's called the Active Care. Company is MCS. Out of a disclosure, I am a paid consultant for MCS. I'm probably one of about 9 or 10 orthopedic board members. Okay. So this is an overview of what I'm going to be talking about. There was an MCS code request that already occurred. There was a preliminary decision by HCPCS. The company had concerns about this preliminary decision, which I'm going to describe a little bit, and I'm going to try to give you an explanation of what this Active Care device is, why it is different, and why it may deserve a new code, and some recommendations. And this is the request for a different code than this E0676, which I think the device is very different than other intermittent limb compression devices. I'm going to give you a talk about this. You'll hear it verbally, and this is a lot for you, just information that maybe you can read later. But that's a busy slide. I'd really rather just go into some of the details more descriptive from slides like this. What we're trying to do is prevent blood from sludging in veins. And when they sludge in veins, they form, let's see if this pointer works. They form a blood clot if the venous blood flow goes too slowly. And when they form a blood clot like that, that leads to a deep venous thrombosis. And sometimes that blood clot can break away, and then it'll go up the veins, and it can go into your lungs. Gets into your lungs, it causes the PE, which is a pulmonary embolus. This doesn't happen to everyone with a pulmonary embolus, but a lot of people die from PEs. It's horrible. We all have to face this at times, and we would like to prevent this. In fact, there are estimates of over 300,000 U.S. deaths from PEs of various sorts from a lot of different causes in the United States annually. Many of these are extremely preventable. Even if you survive a PE or you don't get it, but you just get a blood clot distally, you can get venous stasis changes and legs that are swollen for the rest of your life. And we'd like to avoid any blood clot. Now, typically the way we manage this is we give patients these agents by mouth or injections. They're pharmacological agents. They typically make your blood thin. By making your blood thin, they don't have the tendency to clot. The problem is they do work pretty well, but they have a lot of side effects, and the biggest side effects are bleeding. The bleeding could be at the surgical site or could be anywhere. And just personally, I remember when I first got to Sinai Hospital in 2000, I had 5 bleeds in 2 weeks because I was forced to use certain agents because I had just came to that hospital from Hopkins. 5 bleeds that had to go to the OR within 2 weeks. When you go to the OR to evacuate a hematoma, that increases the risk of infection and increases mortality. So we'd like to avoid bleeding if we can, and it can be very difficult with a lot of these agents. So fortunately, there are a number of mechanical things that have come on the market. This is the one that to me has saved my life. This is the Active Care device. You can see some of the features. It has cuffs, it's portable, it weighs like a little bit more than a pound. It is battery operated. It's not something that you plug in the wall and then when you have to go to the bathroom you have to pull it out, which is some of the other devices. It can monitor compliance, and I'm going to show you all the studies and why I think this is a device that's superior to the other ones. This device actually squeezes in a regular basis with your ventilatory cycle. It's not something that just squeezes. Many of the devices that are on the market, even the ones that plug in, they squeeze for 10 seconds and then they're off for a minute, or they squeeze for 30 seconds, and they have nothing to do with the patient's physiology. Another thing, this device has actually been head-to-head scientifically against other devices like foot pumps, and this pushes blood right up your venous circulation, right through your thigh, and it does it very effectively. A lot of the other devices on the market, they've never even had these studies, or the ones that have had the studies like certain foot pumps, they don't really push that much blood. And you can just think of it, you need to push the blood because that's what prevents it from sitting there and forming a blood clot. So by using this device, I don't need pharmacological agents, and I haven't been getting bleeds. I haven't brought any patients back to the OR to wash out hematomas, or very rare occasions. I shouldn't say never, but for maybe other reasons, for hematomas or excess blood. So I want to show some of the studies that have been done, and there have been a lot from MCS. This is one before I was involved from the Cleveland Clinic, and they compared this device to another intermittent compression device. This was like something that you could wear, but then it had to be plugged in. You'd have to take it off when as I said, when you went to the bathroom or got into bed half the time. The Active Care was used at least 18 hours a day, and you can see that the difference in these both were combined with a pharmacological agent. But there was a decrease with the Active Care device. There were no pulmonary emboli versus about 0.7%. The bleeding, the DVT rate went way down from 4% to 1.2%. So this was a retrospective study, but it was very interesting. Then I was part of this study. This is a prospective randomized study. Myself at Sinai Hospital and I believe 9 other centers, Special Hospital for Special Surgery, the Mayo Clinic, Scripps Clinic, and comparison of direct Active Care, that's it. Some of the patients had aspirin, but versus enoxaparin, which is a low molecular weight heparin, which is a blood thinner. And what was found was there was pretty much the same incidence of venous thromboembolic disease or blood clots, but there's no bleeding in the Active Care group. And you wouldn't expect any bleeding. You're just pumping. You're not thinning the blood with that. So that was a very important study. There's an information sheet that I gave out to you that has my involvement in dealing with venous thromboembolic disease. I was the co-director of the AOS committee that actually put out the guidelines the last time the guidelines were written at the end of 2011 and the beginning of 2012. When this study this study was published before those guidelines came out, and I then was on the guidelines, and because of this study, the Academy accepted that mechanical means alone could be used to treat patients that have had a hip replacement or a knee replacement. Before that, it wasn't totally accepted, and because the AOS accepted mechanical methods, such as this one, then the ACCP, which is a group of pulmonologists, a whole group of different specialists that also have guidelines about using anticoagulants and using different prophylactic agents for DVTs. They also approved mechanical devices, specifically this one, for the prevention of DVTs as standalone. And I'll show you that a little later. This is another study that just looked at a registry which I participated in, and it showed that there are very low rates of DVT or PE using this device alone. And that's tremendous. So you don't need the pharmacological agents. Here are the ACCP guidelines, which I just told you about. You can see circled here, they're describing that they want 18 hours a day. A device can be used, intermittent compression device. It needs to be used for 18 hours a day. We need to assure compliance for the patient. Now, there are other devices on the market that say that they have compliance. First of all, the mechanical means that are accepted may range even from just wearing a stocking, and that compresses the veins, or foot pumps, which to me are not that effective at delivering blood up. They've never really been studied, and there's no compliance monitors on them. Some of the other devices that are out there, they say they have a compliance monitor, but you just turn the thing on and it's at it, and you're compliant. You could attach the thing to a stool, and it would say it's being used. This device that we're talking about here, the only way you're compliant is it would have to be wrapped around a leg, because it's actually monitoring the flow of blood in that particular patient. And that's what they're talking about with these guidelines. And those ACCP guidelines that I just showed you is what SCIP typically uses. And SCIP in January of this year adopted those guidelines to say that this is standard of care, that you can use this device for the prevention of DVTs, PEs. Now, this is another study that I participated in. I can't dismiss costs of devices, and I don't know how relevant that is for this group here, but I like this study. You can see that the difference between using active care and a low molecular weight heparin, which is one of those anticoagulants, was close to $400 per patient, factoring bleeding and the different blood drawing and everything like that. Now, if you extrapolate that, there's 1 million joint replacements done a year. So if you extrapolate 400 times 1 million, you're talking about a $400 million saving. So even the costs are incredible, let alone all the morbidity and the mortality that you're saving. And I know that what $400 million doesn't mean anything to the government, because the government only talks about billions. So let's just say the 10-year cost saving is $4 billion if you were to use a device like this. So I got it into the billions at 10 years. All right. This is a little bit busy, but I've told you some of the reasons why I think this is an important standalone device. We do 1,500 joint replacements at my hospital. I would say there's 1 or 2 a year that don't want to use this device because they find it annoying. 1 or 2. But if you're given a choice between this device, a portable device, to wear for 10 or 14 days versus taking agents in your mouth that has complication rates, or you have to get blood draws all the time or get stuck, it becomes a no-brainer for the patients. Occasionally they don't like this. It's been used by over 100,000 patients, from one end of the country to the other, different hospitals. This is a busy slide. This is a busy slide. But what I really let me just emphasize, why is this different from the other devices? Just a few take-home points. There is basic science behind it. These are vastly different than the other devices. They know that this shoots blood up the legs. The other devices, they don't know what that's doing. A lot of them aren't shooting the blood that much. They're just stockings and certain foot pumps. They don't even do that. We know the clinical science is there. I just showed you these studies. They're incredible results, standalone. The other devices do not have these studies. Maybe they're trying to piggyback on these studies because they're saying they're all the same category, but they're not the same device. The AOS and the HCCP guidelines actually recommend this specific device, or one that has this profile, and this is the only one that has this profile. And I can't emphasize how important it is to have something that measures patient compliance. That's the knock on all these devices. Oh yeah, they work. For me, Dr. Mon, oh yeah, these work, but the patients will only use them 20% or 40% of the time. Well, you can document that, and you know that behavior. So this has changed my life dramatically. I don't have the bleeds that I was telling you about. The other thing is the company, Medical Compression Systems, also obtained an independent coding company to actually analyze this, what I'm saying, and to see, does this deserve another code? And they came up, and this slide describes that they came up that this device really is a device that is distinctly different from the other ones in the market and does deserve its own code. So I thank you for your attention. On that sheet that I gave you, some of this may be a lot to digest in a short period of time, but I left my cell number and I also left my email. I'm happy to talk about this offline or after this meeting at any time. So thank you for your attention. Other questions, or I guess we have other speakers? Okay.
Okay, our first 5-minute speaker is Dr. Adam Harris.
Good afternoon. Thank you for the opportunity to talk a little bit about this device. I'm a board-certified orthopedic surgeon, fellowship trained in adult reconstruction, so that the vast majority of my practice is hip and knee replacements, and I do somewhere between 350 and 400 of these per year. About half of them are knee, about half of them are hip over the course of the last many years. And I'll say, like Dr. Mond, many years ago I fought with the issues of bleeding, particularly bleeding into the knee replacements. And I'm going to diverge a little bit from the major focus of my talk here, but the American College of Chest Physicians for many years was very adamant about using very aggressive blood thinners such as enoxaparin and fondaparin, etc. And now there's a whole new oral generation of factor Xa inhibitors. And these are all very powerful blood thinners. And they insist that it's acceptable to have somewhere around a 6% rate of major bleeding. And then major bleeding is defined as requiring 2 units of blood transfusion, bleeding into the brain, bleeding into the retroperitoneum. In other words, close to dying type of problems for the most part. Now, in my entire practice, I don't know that I've seen any patients who truly had major bleeding according to this definition who weren't also on some major blood thinner. But the bleeding that goes into the knee that requires evacuation, as Dr. Mont described, is not a minor bleed to the patient. It's increased pain, increased stiffness, poor long-term result, etc. And so for many years I've been fighting with the way to try and diminish the amount of the so-called minor bleeds into the knees as well. And then this device comes up on the market, and I think it's significantly different, mostly, at least in my appraisal, that it is a smart device. It senses the way that you're breathing. I've worn this device personally around the conventions where they try to push it, and if you're exercising, it's pumping more frequently. If you're a little bit more sedentary, it slows down and does match your breathing rate. So at least from personal experience, it seems to do that. So it's the only device which has a head-to-head comparison or comparative studies with the aggressive blood thinners such as enoxaparin. And so the combination of the fact that it can sense how the patient's breathing, synchronize the work, synchronize the sequential compression and maximize the blood flow, sets it apart from any other device. Now, that the concept of ambulatory compression devices seems to be something good has now sponsored a number of copycat organizations that have come to me from time to time, more so recently, trying to say, well, we're every bit as good as the MCS. And so all of these companies have said, show me your peer-reviewed article that proves that you are as effective as Lovenox or enoxaparin. And so far, as soon as I say that, they all go running away. No one's come back with any data. Now, I'm here today on my own time. I'm not employed by the company. I am not a consultant in any form. I'm just an orthopedic surgeon who believes in the device. Now, I've used it for several years now, probably more than 500 patients, mostly knee replacement patients, and have had no major bleeds and have had no detectable blood clots in that group of patients. And so I think I'm here mostly to answer questions after that. Any questions?
Yes, two.
Okay, thank you.
Our next 5-minute speaker, Rhonda Fellows.
Good afternoon, and thank you so much for the time and the 5 minutes to stand before you. I've been in the DME industry and medical industry for over 28 years, and being in this industry, I'm familiar with you and with this process. Medical compression systems has a device and a technology that, to me, is unprecedented from the things that I've done. I've been president of associations, I've participated on boards. I'm here because in defending this device to have its own code, because when we look at EO676, it doesn't clearly describe. When you look at the long descriptor and short descriptor, this device, I call it a game changer. And being a game changer is compression was typically used inpatient only. I think we all, either through our parents or a loved one that has had an open surgery, has experienced compression. This device, as Kathleen had shown, it's 1.5 pounds, very light, but you can walk. Patients can ambulate. As we know within orthopedics, if we can keep you moving, we'll keep you healthy. You'll heal quicker. The patients can continue to wear it. So why is it a game changer? It's a game changer because now it is going and it's outpatient. Patients typically, as our studies will show that we have presented to you, is 10 to 14 days wear time. So we have seen great results, as evidence has shown, little bleed. We have a device. We would love for you to look at it, try it afterwards. I won't take any more of your time, but as I'm here, I'm asking you for a new code. I am with MCS. I'm the Vice President of Reimbursement and Government Affairs, so I am an employee. Sorry. Oh, one other thing. We had a study that was published, lead article, peer-reviewed, JBJS, after our application was submitted. So I have this here to hand out and submit to you. Thank you.
Our last 5-minute speaker, Rick Randall.
Last speaker of the day. How about that? I'm Rick Randall. I'm the CEO of Medical Compression Systems, and I just wanted to kind of piece this together if I could. We all use smartphones, I believe, and yet many of us in the audience at one time may have used a Nokia phone. So all cell phones are not created equal, and we wouldn't think today of using a phone that you could only speak on and not do other things. And that's why we're here. When this company was formed, compression systems had been around for a number of years. As Dr. Mont mentioned, they all did the same thing. They squeezed in a certain fashion for a certain period of time to attempt to move blood flow north from the veins to prevent coagulation of the blood. However, the thought at the time was if we could make this a smart device, we could actually increase the venous velocity to the point where this could be a reliable anticoagulant, but a mechanical anticoagulant. So that's what the company did. They worked on a device that was different. It was synchronized to the respiratory system, and they proved clinically that we could create more venous velocity, less coagulation, and then they miniaturized it and put a compliance meter on it so that you could even think about sending a patient home for the duration they would normally be on powerful drugs. And instead of having the drugs on board, they would be using this device as their sole anticoagulant therapy. When we came to the United States, the clinical setting in the United States, we were given very clear instructions. You need clinical effectiveness research. So we started to prove that not all devices are created equal, and we did that Cleveland Clinic study where we went up against the device that they were using in the hospital every day. Their protocol was to put the device on the hip and knee patients in the operating room, then to continue using the device until they're discharged from the hospital. And then they did a study where they did an ultrasound to detect blood clots, and when they used our device, they saw a 70% decrease in the blood clots. That led to creating enough confidence amongst our surgeon base to then do the actual randomized control trial. We did that. That's a safe study, and we showed that we were statistically significantly safer by having no bleeding complications. We knew that would be the result, but it wasn't powered to show efficacy like we wanted to show efficacy. So we went back, and the last study was a 3,000 patient registry powered and designed to show efficacy. So can we show that over the long haul that this is just as good as any drug? And we did that. The ACORE study was a lead article in the February JBJS, where we show we are non-inferior to the leading drug in the market, Lovenox. So now the clinical research is behind us. We've proven statistically significant safety, efficacy. We've done all the work the community has asked us to. Now we're on an uptake with many patients getting this device, going home every day with this device, as you've heard about. We've moved the guidelines for the first time in 23 years. The ACCP has been working against the orthopedic community for 23 years, and they finally added that guideline because of our clinical data. And now there's guidelines that protect every one of the patients and the physicians prescribing this device. The last piece that we have is to get a fair reimbursement for the device from the Medicare, and also to prevent folks who haven't designed the device to do what we do, that are piggybacking on this device using our clinical data to indicate to orthopedic surgeons around the country that now you can use this instead of drugs, and sending an unproven device home with patients. So that's why we're asking for a specific code to we're not asking for a code without giving you strong clinical evidence and guideline changes that have preceded this ask. So I thank you for your consideration.
Is the thought that both of these devices would fit into the code descriptor that you suggested?
Yes.
Is there a way to say synchronized flow technology without using the terminology that you use in the name of your device?
So to change the name to synchronized flow technology?
That terminology was in your suggested descriptor, and that's also part of the name of the Active Care Plus SFT. So is there a way to describe that without using that terminology?
I think that it was going to be merged to just call this Active Care as one name, but maybe someone else can comment.
Asking the question the other way around. If you've got SFT as part of the name of the device, can the description from CMS?
We try to use more general language.
I see. A generic term for what this is. Yeah, I think that would be
What would it be for synchronized flow technology? What would be a way to describe
well, maybe
that without...
flow enhanced technology, or some way of, I mean, we're thinking...
well, you hear where I'm coming from. I mean, that's like part of the name of your
Yeah,
device,
you don't want to use the trade name, the trademark name
right.
in a descriptor.
And
So
you would,
I'm just wondering
and
what
in the
your suggestion
descriptor, so
would be.
maybe that's worth discussing, should have that that's absolutely compliant, monitored, which is what the ACC.
Well, I don't have any problem with the monitoring capability. It's the synchronized flow technology that's causing me angst because that's part of the name of your device.
Absolutely. And what we would like to do, if it would be fine, let us go back and put our heads together and come up with a suggestion other than synchronized flow technology, if that would be okay.
Proprietary name.
Absolutely, and I understand that. I understand that. Can you give us a couple of hours and I can email it back to you, or no? Well, okay.
Well, close of business
Start
today.
thinking.
Close of business today is the end of comments that the work group will be able
Okay.
to consider. And sometimes when we ask a question, folks think that by just based on the fact that we've asked a question, we've extended the deadline for comments, and we haven't, which kind of puts you in a tough position. So, I mean, if you can give it some thought and you and your car on the way back to the airport, you know,
And your
just send
close
us
of
your
business?
ideas. Pardon?
What time is your close of business? Today. You said
Yeah,
close
today.
of
Well,
business.
like typically 5. You know, if you send information afterwards, we just lose our ability to guarantee that the work group will be able to consider it, is all.
Okay, thank you.
I have a question. Is your equipment is much better than the other compression equipment available?
Yes, we iterated the device over 3 different generations. And the last generation, which is the device that we took to the randomized trial and the registry, has this gated flow. So it's synchronized to the rhythm of your breathing. So basically it pumps when the femoral valve is open. So by doing that, there's little resistance and you have high velocity flow. The other devices are not synchronized in that fashion. So you don't get the velocity of flow that ensures that you will not get a coagulation behind the leaflets of the valve. Yeah, one of the early studies we did in the early 2000s was a ultrasonic study where we compared it to the leading device on the market at the time. And that led us to the Cleveland Clinic retrospective study where we compared the clinical results with, so we knew we had a different hemodynamic profile, but does that mean you're going to have less clots? That's why we then moved to the Cleveland Clinic study, which showed less clots even with the drugs on board. They didn't have enough evidence at that time to feel they could move away from the drugs and the device. So we did that study. The results of that study gave them the confidence to go solo as a monotherapy head-to-head against the Lovenox. That was the randomized control trial. So there was a sequencing of events, but it started with, is this device different than what's on the market today? Can the smart technology create a different hemodynamic profile that should lead to less clot formation?
Okay, so I'm delighted to see all the attention being paid to clinical studies. Thank you for that. I think we have a little bit of a ways to go. We've heard discussion about that there's a different mechanism of action between your device and other outpatient, let's say, devices. What would matter to us in terms of coding, and I know you've consulted with an expert coder, but CMS publishes its own coding logic and the reasons that we use to break devices out of existing code categories and create new code categories, or to establish new codes, which may be different than, whatever criteria other people want to use or advise you on. But if your product, and this is where I see you on the decision tree, uses a different mechanism of action, I don't mean from anticoagulants, I mean from other similar devices that would be used in an outpatient setting, not the big hospital stuff, but the other devices that a person would use in the home. If that mechanism of action leads to a significant therapeutic distinction, that is, a better clinical outcome, and you're able to demonstrate that through clinical studies, that would be pretty meaningful. So, just because the device might be smaller or miniaturized by itself doesn't mean that it's unique or that a patient would benefit by use of that as opposed to another similar product. Compliance monitoring is neither a treatment nor a clinical outcome, so that isn't likely to carry any weight. But your synchronized flow technology, it seems to be your claim to fame based on your own words, and that sets it apart from the way other devices operate and leads to less bleeding, less clotting. And so a study that's not head-to-head, your device versus a hospital-based unit or your device versus anticoagulants, but a study of your device versus other devices that otherwise share the same code category would be pretty meaningful. And you seem to be a group that's interested and willing to do studies, so I thought that I would bring that up.
The closest to that specific study is the Freumsen study that I showed you, where there's a combination of anticoagulant with two different devices. And that was clearly a difference. One has a PE rate of 0.7 with the other device, with ours at 0, with this MCS at 0, not ours. And then the DVT rate was over 1/3 down. It was 4.2 to 1.3. So in some ways, I hear what you're saying, but it's almost, and I guess it's for the company to decide, it becomes a little unconscionable because I know the way what was just described, the waveforms go with these other devices. They're not predictable. And I couldn't, I'm speaking as for my patients, I couldn't put another device against this device. If I did, I'm based on that study and what I know about the compliance, which does occur because people have to go to the bathroom and they get up. What I know about how this blood is going through the legs, I know what's going to happen ahead of time. I'm going to have more deaths, more DVTs, and I guess the simple answer to your question then, the only way I could do this is by retrospectively collecting data. It's not perfect. I do studies like that all the time where I show that this surgeon in this hospital, but it's never this, it's two different surgeons though. So even that's not perfect, but you can show that using foot pumps or other devices just had way worse outcomes. And actually I think that data does exist.
Yeah.
Because if you look in the literature of what you're asking a head-to-head, that doesn't exist except for what I just said. But if you look in the literature, the other devices do have higher mortality rates, higher DVTs, and higher PE rates than this device. So that's actually out there. I mean, maybe that just needs a review. But it's hard. It's hard to do exactly what you're saying. For me personally, I can't.
That's why we did that. Okay. Can I make a comment here? I'd like to draw the analogy, the old saying that a stopped watch is correct at least twice a day. And in the same sense, if you talk about the mechanism of action, yes, this device squeezes a leg like other devices squeeze legs, and it may have a little bit different timing here, a little bit different pressure. That doesn't set it apart. What sets it apart is that it monitors the respiratory flow rate so that more than twice a day it compresses exactly when it should to maximize the flow rate. And that's the SFT technology that drew me to it as a clinician. And that, I think, is what sets this device aside from all the other devices.
The logic behind the Cleveland Clinic study was exactly, we had already performed some earlier studies that showed the hemodynamic difference between devices. But the clinical community here was not ready to begin to think about using this as an alternative to drugs until we've done a head-to-head study with the device and the drugs on board with the conventional device, and that's the Freumsen study. So that was the logic, exactly to your point. The logic was, let us see now that this device creates a different clinical result in a true clinical setting compared to the device that we use every day. So it just so happened that the clinic, they were one of the few hospitals at the time that was putting the device on hip and knee patients in the OR just prior to surgery. And the significance of that is blood clots begin to form the moment you're under anesthesia, and that leg is basically dead. So that we put the device on then. So that was their protocol. So we followed that same protocol and showed a 70% decrease in clot formation. So that was the clinical study comparing technology to technology that led to then the next step, which is, okay, let's go randomized against the drug. So they followed your exact logic, I believe, and that's, it cost us another year of time to be able to prove that, but it was a valuable thing to do. The other thing I'd like to just point out is mobility and the compliance measurement is very important. We actually added the compliance meter to the device, and we engineered it so it was true compliance. If the patient takes it off with the on switch on, it's not going to measure compliance. It has to be on the patient. Why is that? Well, before Dr. Mont is willing to send a patient home for 10 days with a device without drugs on board, we have to know that that patient's going to be compliant. And we determined a long time ago that if the patient would have this on for 18 hours or more a day, that level of compliance was going to lead to the right clinical result. So now every patient that goes home with a device, the meter shows them compliance, and they get an audible signal. They are told if the device is if they're not compliant, and that leads to the proper behavior to put the device on. And now, how do we measure that? That was another reason to do the registry. Because in a 400-patient randomized controlled trial, you have a lot of control over the patient's behavior. In a 3,000-patient registry, that's more of that mimics the normal behavior of those patients. And what we saw in the ACOR study, the large registry, was that fortunately our DVT rate was below 1%, equivalent to the drug, and that also told us that the compliance meter does work. Because the patient, if they didn't wear it for the required time, we would have much more in the form of DVTs or, God forbid, even pulmonary emboli. And we had a very, very low rate. So I think two things that are very important in distinguishing the device are the mobility, so the patient doesn't have to unplug a device to move around with it, and the compliance meter, which constantly reminds them whether they're behaving. It's just like taking their drugs. They need to know they got to take their drugs every day. They need to have this device on, and it works.
All right, well, thank you.
What if we use the term synchronized pneumatic compression? Because this is a pneumatic device just like all the other devices, but it's synchronized. Okay. We'll keep working on it. Thank you.
Okay, what a day. Very, very thought-provoking conversation and discussion here. We would like to thank everyone who participated on today for all of your thoughts and for the discussion. We thank you for providing your comment and taking time out of your busy schedules to come in today to provide your input. We look forward to working with you in the future, and we thank you and say have a wonderful day. This meeting is officially adjourned.